Welcome back. And thank you for being on time. We have a full afternoon planned for you that includes polling, session evaluations, and a leadership chat. If you are joining us for the first time today, please take note that using an Ethernet connection instead of Wi-Fi and using Google Chrome instead of Internet Explorer can increase webcast streaming speed and prevent delays. We are featuring polling during our event today. Thus, if you have not reviewed the polling instructions, please do so. You can find the participant instructions posted on the CTEO website. If you have questions for our presenters today, you can submit your questions at any time by following the SurveyMonkey link that can be found also on the CTEO webpage. And for all of our viewers, continuing education unit credits are available for today's event. And the surveys to complete in order to get those credits also are on the CTEO website. We did have a question come in about whether or not the presentations, the videos will be posted. And the answer to that is yes, they will be posted on the CTEO website at a later time, but they will be up there. Okay. All right, so now that we have all had lunch, I wanted to poll all of you again and see how you are feeling now, a little later on in the day. So please click on the emoji that represents how you are feeling now after lunch. I'd say the first one looks energized. The second one is saying, oh my gosh, I really shouldn't have eaten that. The third one is, boy, did I eat too much, now I'm sleepy. And the fourth one is just having a bad day. Uh-oh, we have a lot of sleepy people out there, so you guys have your job cut out for you. All right. So moving on, I'm happy to introduce to you our next speakers who will provide a year at a glance for the Medicare Part C and D program. From the Medicare Drug and Health Plan Contract Administration Group, we have Catherine Coleman. From the Medicare Enrollment and Appeals Group, we have Jerry Mulcahy. From the Medicare Parts C and D Oversight and Enforcement Group, Vicki Ahern. From the Medicare Plan Payment Group, Jennifer Harlow. From the Drug Benefit and C&D Data Group, Jennifer Shapiro. And from the Consortium for Health Plans Operations and Regional Administrator for the Boston and New York Regional Offices, Ray Hurd.
Did you have to say all that?
I did. All right, thank you.
Good afternoon. I'm Catherine Coleman. It's our pleasure to be here with you this afternoon. Thank you all for joining us in the audience as well as online. It's exciting to see so many people here and so engaged in what's going on at CMS. This afternoon we wanted to talk to you a little bit from a leadership perspective and give you a better understanding of all of the various things that go on throughout the year with the Part C and Part D programs. And we thought it might be interesting to share a little bit of the behind the scenes at CMS and what it's like to see the program from our perspective and all the work that goes into the various touch points where we reach out to all of you and you reach out to all of us and how that all fits in and how all of us work together as a collective team. So with that, I will hand it off to my colleague Vicki to start the show. And this calendar here, this visual here is a calendar of all of the various important things that we see throughout the year and you see as well, and kind of how they stretch and the work stretches throughout different periods and points in time.
Great, thanks, Catherine. So we'll start with audits. We basically go throughout the entire year. Our audits are designed to ensure that the beneficiaries receive the medically necessary health and drug services, but our audit activities actually span the entire year. As many of you know, since you've been through an audit, from an engagement letter that comes out until actually the audit closeout, that time period can be over 1 year for a sponsor. The selection of who we're going to choose for an audit each year actually begins at the end of a calendar year when we base that on our risk assessment along with other factors. But then at the beginning of the year, when we start to work on our scheduling, we take into account a variety of information, such as an organization's enrollment size, which PBM they use, what their risk level was from our assessment. And then we actually send out our first engagement letters, typically in February of each year, with our on-site field work starting in early April. Our audits actually involve a large number of resources and a lot of coordination. At the beginning of the year, we actually staff most of our audits with central office employees as well as some of our contractors, because the regional office counterparts that help us later in the year are reviewing applications. And then typically in May is when the regional office staff, along with some of our contractors, conduct the audits. During our audits, we also rely on all the other groups that are represented at this table. So if an issue comes up, we can reach out during an audit to the subject matter experts who are in each group to help us clarify any policy or other issues that may arise. So following the on-site portion of our program audit, the program audit consistency teams, which we've implemented, actually meet together and review the findings from each of the audits, and then they actually classify the conditions. And then based on that, if needed, audit findings are referred over for evaluation to determine if any type of enforcement action is warranted. So throughout the year, we're also collecting feedback from the audits and from the sponsors on any policies that may need clarification or any processes that may need to be improved or streamlined. And then we share that information with our colleagues here to help inform any changes that need to happen. And then last but not least, after we release the final audit report, some sponsors may be required to hire an independent audit validation contractor to test and report to us the correction of their deficiencies. So with all this being said, multiple audits occur simultaneously throughout the year, and activities as the year goes on actually exponentially grow. So at some point, we're sending out engagement letters, while at the same time we're conducting on-site audits. While PAC teams are meeting, we're drafting reports, we're going through validation. So as the year goes on and different sponsors are through different phases, we're doing all of that at the same time. And then the validation, as you know, after the audits, carries into the next year. So we're finishing up and validating and closing out audits from the previous year at the same time that we're actually planning and conducting audits for the current contract year. So this takes a significant number of employees and resources, and we really couldn't do it without the help of the region. So I was just going to turn it over to Ray for a minute to just talk about how he works with his team to resource our audits.
Thanks,
Ray?
Vicki. So we have offices in all 10 regions across the country, and when it comes to the audits and who's going to be on the team, it's really a management of workload. It's not just the MA-PDP audits we do. We also do PACE audits. As Vicki already said, we review applications. So it's looking at, do we have the expertise available? Do we have the workforce available? And how much travel is involved to put those teams together? We have started adding observers to the audits so we can develop deeper experience and have more people available to do the audits. But in the end of the day, it really comes down to just reviewing the workload and what resources we have available to be able to do those audits.
So that brings us to the call letter and the rate announcement, which are two key documents that we put out providing program policy updates. And the whole process is a team effort across all of the groups. The advance notice and the rate announcement are released according to statutory requirements. However, a lot of effort goes into these two documents, and we factor in a considerable lead time in prepping for them. The draft and the final call letters have in past years been released with the advance notice and the rate announcement respectively. So I'm going to turn to Catherine now, and she's going to provide some more information about the call letter.
Sure. So we always try to tie the call letter's issuance with the rate notice. And that helps us with the clearance process and helps keep us on a timely and orderly calendar. So although we don't release the final call letter until April, we're already, actually today, going through the topics that we would like to include. So it's far in advance of the final draft that you all will see, or the initial draft that you all will see, that we start putting the words on the page. So it takes a lot of time and effort on our part to get that initial draft together, and then we also have a clearance process through both the department and the Office of Management and Budget, as well as our own leadership here at the agency, before that letter gets released in draft. And as Jennifer mentioned, we coordinate across all of our groups. We also involve the Center for Medicare and Medicaid Innovation and the Medicare and Medicaid Coordination Office that runs the duals demonstrations. They often have pieces that they would like to include in the call letter, important messages they want to share with the plan and sponsor community. So we coordinate with them. We look at different policies that may have evolved over the past year that we want to clarify or enhance. If there's coverage decisions that have been made on the fee-for-service side, and we know that plans are going to have questions about whether or not they have to cover a particular service and how it gets paid for, all of those things get incorporated into the thinking and the drafting process. Jennifer, do you want to wrap it up on anything else that you wanted to say?
I think that's great.
Okay.
So I was just going to mention one thing. We benefited from the request for information process on last year's call letter. So we are considering that and reviewing it for items of topics that would be beneficial to put in this year's call letter.
Right, and we always have to time it, obviously, to get it out in advance of the bid deadline, which we'll be talking about next. So as you all know, the bid deadline is always the first Monday in June by statute. But there's a lot of work with getting ready for bid review that goes on behind the scenes well in advance of that. In fact, the systems changes sometimes are a year or two out in planning to make sure that we have the tools and information to collect from you all electronically established in the HPMS system. So the call letter generally provides that guidance. We issue bid instructions in the early spring after the call letter has been issued to give you direct information and feedback about what we're looking for, more technical information. Obviously, we do the bid review approval once they're received, and that runs between June and August of each year. We have staff going into the system, looking at the notes, looking at the different items that we've collected, making sure they meet our requirements. On the Medicare drug benefit side, you all are looking at formularies, Jennifer, and
Right.
different items on the Part D side.
Right, we've got the formularies, the transition policies, medication therapy management, all sorts of things. I think what's interesting and we wanted to highlight in this session today is how much interaction there is among us and the groups here. I think with bid reviews, a lot of the activities are discrete within individual groups, but all of those activities ultimately come together to create the whole process. But as Catherine mentioned, there's one very notable exception to that, which is the health plan management system. And so I wanted to definitely call out HPMS, as we call it, for the work that group does, or that division does in my group, supporting every single aspect of the bid reviews and everything that we collect, how we analyze it, and making that information available for you to submit and for us to look at. HPMS, I think, works many, many, many months in advance with every one of the groups to figure out what the specs are going to be and develop all of the information and the systems needed to make that a very smooth process. And even though we're not going to talk about HPMS's role in each and every one of the rows you saw on the initial slide, it's one of those pieces of our work that really underscores almost all of our groups and many of the activities that we do. So I would have been remiss without mentioning that is a very important part of our integration with both internally and with all of you.
And one of my favorite things to say is that HPMS is only limited by our imagination and our budget.
So we've just completed the rebate reallocation in July and August. The bids were just approved in late August, and then here in September, we will go into the system and actually electronically sign the contracts. So it's a multi-year process, multi-month process that ultimately wraps up at the end of September. I think your water bottle's blocking. The next slide talks a little bit about crosswalks. This involves any of you who make changes and want to seamlessly transition enrollees based on a plan consolidation or maybe a reduction in your service area or another reason that you might want to move membership. And that all happens in the August to December timeframe, usually on the front end of that time period. But another important process that happens very shortly and involves a lot of players.
Even though most of the, the enrollment activities fall in Jerry's group and the enrollment group, there are a number of things that the drug benefit group does, of quite a flurry of activity for the annual enrollment period and to make sure that beneficiaries have the information that they need to pick a new plan. This is another example where it looks like a very specific and discrete point of the year, but an awful lot of work and time leads up into these kinds of activities. So, for example, for getting ready for the AP, we're conducting quality assurance to make sure that all of the plan finder information is correct so that beneficiaries have good and sound information to help them pick a plan. And when in working with other groups, one of the components we work with very closely here is our Office of Communications. So they make sure that everything is working on the website and all that data is there. We also, along with Catherine's group, we are finalizing the benefit offerings and all the contracting for the upcoming year. And then, of course, as everybody knows, we publish the star ratings. And there's a lot of integration and a lot of work that goes into that from all of us. And I'm going to talk about that in a couple slides along the way. The regional offices and us as well, we're looking at the complaints tracking module, making sure that things are going smoothly during this time. We just continue to monitor with regional partners and everybody. So those are just some of the kind of activities that we do that are supporting the AEP in a more data-oriented fashion. So now Jerry can talk about some of the other things.
We can go on to reassignment slide.
Next slide.
There we go. So my area coordinates the reassignment, and that's the process of moving certain low-income subsidy beneficiaries from a plan benefit package, a PDP, that's going above the benchmark or terminating to a plan that is below the benchmark. This occurs about mid-October. And then also we do assignments of any MA beneficiaries for plans that are terminating. Notices are mailed to the beneficiaries informing them of the new plan, and they have the ability to opt out. Plans are sent to files which identify these beneficiaries, and it's the gain and lose file, so it's anyone that they're gaining and anyone that they're losing. What we call choosers are not moved, so if a low-income subsidy eligible beneficiary selected the plan that they're in, even if that plan goes over the benchmark, we don't move that beneficiary, but we send them what we call the chooser notice, and it tells them that they are in a plan that will now have a premium, or the premium that they had is going to go up, and remind them that they have the option to pick another plan that would be at or below the benchmark.
So the next slide concerns applications, and that's something that we also in the Medicare Contract Administration Group share with the Medicare Drug Benefit Group, as well as with heavy involvement from the regional offices. And I know you all probably think of applications as sort of starting up in that January to February timeframe, wrapping up around the end of spring, and then the appeals process and so forth. But we actually start that process much in advance through getting the application itself cleared through the Paperwork Reduction Act requirements through the Office of Management and Budget. So we send that application over to obtain their clearance in the summer. So this year's application would have gone over in June or July of this summer, for hopefully being published for comment in the fall and then being finalized before applications are live in January and February. So we do a lot of advanced work. I don't know, Jennifer, you want to talk a little bit about the past performance review?
Sure. So one of the key aspects of applications is the past performance review, and there was a presentation earlier today that you probably heard that probably you attended, and so I don't need to belabor the past performance, just to say that, like the applications, we start the past performance methodology early, and we're hoping to do that even earlier this year, so you have that as far in advance as possible. And so we'll continue to do the review twice a year, so you'll have preliminary results, and then in the spring we finalize the past performance methodology and use that as part of our decision-making process for applications.
So we look forward every November to seeing the notices of intent to apply from all of you. That helps us sort of gauge where the interest is in MA across the country, and where we might need to deploy resources for the regional offices that play a key role. And Ray can tell you a little bit about the role they play in evaluating the applications as they come into CMS through the HPMS system.
So for clarification, when we say regional offices, we're talking about the account managers and the caseworkers that deal with the plans and the sponsors. They all fall into the Consortium for Health Plan Operations. We do the initial reviews on the applications, mostly because we're in the area, so we understand the landscape, we understand what's going on, and we also have experience with the plans that have succeeded and failed in those areas. So we do the initial application reviews and pass our recommendations back up to the Center for Medicare on whether or not we need more information, notice of intent to deny, or those that are approved.
So our team works very closely with the regional office representatives on the application process. They help us review the applications. As Ray said, they put in their notes as to things they believe are deficient. My team will look at those deficiencies and evaluate them. They want to make sure that we've been consistent in our evaluation across all sponsors across the country. And we work hand in hand with Ray to provide a feedback loop. If we see anything that looks a little out of sync, or we want to modify anything based on their initial reaction. We also involve the consortium in our evaluation of exceptions that you all submit through the HPMS module for network deficiencies. If you're requesting an exception, we look to them to help us understand the local patterns of care, if there's anything that we've missed.
Service area expansions.
Service area expansions, all sorts of things that we work closely with them on. And then, of course, we issue the deficiency notices through the spring, and then our final decisions, approvals or denials in May. And then if any of the sponsors are appealing those decisions, those hearings take place over the course of the summer. And we also work with the regional offices who've evaluated the application as it came in, and any of the feedback that's noted in the system, they may end up being part of the appeals process and the hearings process and testifying before the administrative appeals process. We'll actually have the regional office reviewers participate in that as well. And that generally wraps up usually by the end of August if we're lucky, so that we have all of those things resolved before we have to sign the contracts, before we have to put the information into the plan finder. There's a lot of handoffs that happen that we like to have done by the end of summer at the latest.
Yeah, and the only thing I'd add for Part D is we have a very similar timeline we tie together so that we have the end goal at the same, we're at the same time, but we do our reviews in central office instead of the regional offices. But otherwise, the process is very similar.
So we're coming up on a very busy time, and for my group as well as the others, on the landscape rollout, which is actually statutorily required display of all the plan options that will be available to eligible enrollees for the next annual election period. So we work very closely with all the groups represented here in preparing that landscape, which I'm sure you all are aware comes out generally in mid to late September each year. We pull preliminary data once the bids are in. to give our leadership a sense of where things are going and what the landscape is looking like, where premiums might be headed, where projected enrollment might be, any areas of the country where we might see plans not being available in certain counties. It's always of great interest to not only us, but to the public and to members of Congress where the MA landscape is headed for the next year. So we always try to provide that information in advance of the marketing season, which begins October 1st, and in advance of the AEP, which starts in mid-October. And like I said, we work with our partners in the Medicare Drug Benefit Group and the Office of the Actuary in calculating premiums and so forth and the benchmarks, and that all happens throughout the summer months for the ultimate rollout in mid-September. So looking forward to that in just a few weeks.
Next slide. Great. Thanks.
There you go.
I think star ratings probably needs very little introduction. I think this is probably an area most of you are familiar with. But just for anyone who's new to our programs, this is the quality rating system that we use on Plan Finder to facilitate beneficiary choices, and that also form the basis for quality bonus payments. It is very much a whole year activity, and it's a multi-year at once activity. So for example, we'll be establishing our metrics well in advance, working with our partners to do that. Then there's going to be another year, that's the data collection year, the measurement year. We'll have the following year, that's a publication year, and then another year, that's a payment year. So at any point in time, we could be working on quite a number of years worth of star ratings all at once. And so just to let you know a little bit about how we see our year at any given point in the star ratings, we start the year with the call letter, letting the public know about what measures are going to be in the upcoming year's ratings. And then we're collecting data and calculating throughout the summer. We're also providing reports to plan sponsors throughout the entire year. And then in the late summer and fall, we're finalizing the star ratings. We're doing previews, which is happening right now this time of year, and we're answering lots of questions. And then later in the fall, we're working on QBPs and QBP appeals. And by that point in the year, we're already drafting our content for the call letter that's for 2 calendar years forward. So we try to question ourselves as to what year it might be at any given time, and we often fail that test. I know I do. We'll say this year, but we never mean this year. 2017 is not this year. That's done. So it's a year-long process, and it's a continuous one, and often confusing as to what year. But the other thing about star ratings I wanted to mention is here also there's a tremendous amount of collaboration among our groups to do the star ratings, and not just our groups, but throughout the agency. So for example, we work very closely with the Center for Clinical Standards and Quality. We collaborate on measure development and alignment with the agency's quality strategy. And PPG, the payment group, of course, takes the star ratings and calculates quality bonus payment rates. Catherine's group, they're the subject matter experts for various measures, like the SNP care measures. Jerry's group, Enrollment and Appeals, they're the subject matter experts for all of the appeals measures that we have. And MOEG has measures that they help support as well. And actually, here would be a great opportunity. Vicki, do you want to just talk a little bit about some of?
Sure. So I used to be in the Medicare Drug Benefit Group, so was heavily involved in the star ratings from the very beginning, and I'm fortunate now that in my current role within the Oversight and Enforcement Group, we still get to work very closely with the star ratings. So our audit findings are a source of information that are used for identifying data integrity issues with some of the measures. As well as last year, we started our timeliness monitoring project, which then actually is collecting data across all sponsors so that we can evaluate the timeliness of appeals data. So we work very closely with those in Jen's group on various aspects of the star ratings.
Great. We can move on. Thanks, Vicki.
So that brings us to payment. And payment policy development and analysis occur all year round with, of course, a greater emphasis during the rate announcement season. But in the background, payment operations also occur all year round. And just to give you a sense of proportion, for calendar year 16, we made payments for approximately 18 million Part C enrollees and then approximately 43 million enrollees in Part D. The rate announcement and the bidding process provide a number of parameters for payment, which are then programmed into our different payment systems. And we make monthly prospective payments, plus every month we also make retrospective adjustments, which generally mean we're just adjusting or correcting for payments based on new information that becomes available. We also conduct payment reconciliations for Part C from time to time to update risk scores with more current diagnosis information. And you're probably familiar with the mid-year and the final risk score recons, and also perhaps the overpayment reruns. The payment calculations for Part C and Part D programs are separate and distinct, but the same systems are used by both programs in many places along the way. HPMS provides plan-level information, including specific bid data. And here we work closely with our colleagues in MedBug, who manage the HPMS system. Risk scores are calculated in our risk adjustment system, RAS. And RAS is fed with encounter data and RAPS data, which is another activity for our group, and we collect that data all year round as well. Then we have EDB, which is essentially bringing in data from SSA about enrollees. MARCS is the core payment system, which takes in the plan, the enrollee, and the risk score data feeds and calculates the enrollee level payments. And finally, MARCS passes along this information to our app system, and then our group works with the Office of Financial Management at the latter end of this payment process. So much of what we're doing for C also applies to D, but there are a few added twists. For Part D, we also cost reconcile. And in order to cost reconcile, we collect prescription drug event data, or PDE encounters. And in working with the PDEs, we do frequently partner with our colleagues in MedBug again, and we're basically asking for help from them on data fields and content, and also different aspects of how we process the data. And just to give you a sense of volume here, for any one payment year, we are now collecting approximately 1.5 billion PDE records. In addition to the cost reconciliation data that's coming in, and the PDEs that we're taking in, we also have to incorporate DIR information, and that comes in the June-July timeframe. And then we use PRS, which is another system, which I think of as something like a super calculator to conduct the cost reconciliation calculations. And then lastly, we also do conduct Part D payment reopenings, and generally do one a year, and that's for prior years where we're truing up payments. And we run the coverage gap discount program as well, with quarterly invoicing and payment processing between CMS, the Part D sponsors, and the manufacturers. For both C and D, MPPG partners with the Office of Information Technology just to ensure that all these different systems are working continuously, and that's pretty much around the clock all year round. And then we also have to make sure that all the appropriate software updates are conducted, and sometimes we do these off-cycle as well. And just again, to give you a sense of volume, for 2016, we made payments just over 180 billion for Part C and over 90 billion for Part D. And I think that's a good segue into payment error estimation, which is another function for our group. We're required by statute to estimate and report an annual payment error estimate for both Part C and Part D, and these numbers are released publicly. For Part C, we measure the extent to which diagnoses submitted for risk adjustment are supported by medical record documentation, And then for Part D, we validate PDEs with information from prescriptions and also other claims documentation. For both of these error rates, we pull samples in the fall timeframe, and then we request the documentation. And I think as many of you are probably aware, we do this after the new year with deadlines generally in the late spring or early summer timeframe. Then we have coders who review our medical records, and we also have reviewers for the prescription information and the claim documentation. And that means that by the end of the summer, we're generally in a position to calculate error rates. And then those error rates are published in the AFR, or the agency financial report, in November. Last year, we reported error rates for calendar year 2014 payments, and for the Part C error rate, we were at 9.99%, which equates to about $16.2 billion, while for Part D, our error rate was 3.41%, which equated to about $2.4 billion. So at the same time as we're working through all of these payment error estimations, Mudbug is focused on the checklist readiness, or the readiness checklist. So at this point, I'm going to pass the conversation back to Jen.
Okay, great. The readiness checklist, I hope many of you are familiar with it, is something that we issue annually, and we've done that since 2007, typically in the September or October timeframe. And the goal of the document is to summarize what we think of as the most critical operational requirements that you all should be thinking about, focusing on, and planning for in the months leading up to the new benefit year. And even though we stress that this is the most critical elements, it's more than 20 pages of them. So I think it gives a sense of the complexity of the program. And what we're trying to do here is boil some of it down and put it all in one place, at least those that we think that are deserving of the most attention at that time. And it includes the 13 topics that are on the screen, like reporting and marketing, beneficiary protections, and so forth. You can see the list. And this is as cross-cutting as it gets. Every single one of us plays into the readiness checklist. There's subject matter experts in every group and actually in other parts of the agency as well. So it's certainly as cross-cutting as any of our activities. And we've heard from plans in the past that it's very helpful to you. We certainly hope so. This is not a place where we add any new guidance or new requirements at all. It's just a summary of what we've already told you and a reminder of that. And then we expect plans, MA organizations, and Part D sponsors to use it to conduct an internal assessment to figure out where you are. So those are our goals with it. As I said, we all contribute to it. Did someone want to give an example of one of the things that your groups highlight in the readiness checklist?
Sure. In the enrollment area, one of the things that we're concerned about is the ability of the plan sponsor to be sure that they're ready to submit current calendar month enrollments, as well as doing the ready to submit retroactive enrollments to the retroactive processing center. And so those are two distinct and different operations, and we really like to make sure that sponsors are ready and prepared to do both.
And last year and this year again, we have had our account managers in the regional offices conduct strategic conversations with their plans to see how the readiness checklist process went, and are there any concerns? So Ray can talk a little bit about that.
Yeah, I'm going to talk a little bit about strategic conversations in another slide, but last year we went from an attestation on the readiness checklist to a strategic conversation and received positive feedback from organizations and sponsors, as well as from the account managers, that it was a more beneficial process. So we're going to use that approach again this year.
Great. We can move to the next slide. I was happy to get a chance to talk about essential operations, what we call essential operations testing, because unlike readiness checklists, which I think most of our partners are very familiar with, many of you may be less familiar with essential operations. And the reason that you're probably less familiar with it is because we just started conducting these tests in the last few years, and only for new applicants for Part D that do not have any Part D experience at all. So by this point in the program, most of our partners have a great deal of experience, and even plans coming in might be partnered with some kind of very experienced organization. So what we're looking at here is how ready are new applicants to our program who truly don't have any Part D experience at all. And the regulation gives us the authority to terminate a new plan's contract if they're unable to pass this test. So it's not a small thing, and we take it seriously, but we've created a process that we think is fair and it works. So for those, many of you who haven't been through this, it's an in-person test that requires the new sponsor to demonstrate their in-house knowledge of Part D requirements. And so the expectation is that the sponsors are familiar with all of the key beneficiary protections and benefit administration requirements, and is also prepared to oversee their subcontractors who are often performing many of the key responsibilities for their Part D operations. So what happens is the Part D sponsor comes here on site. They usually bring their compliance officer, medical director, enrollment director, pharmacy director, and Part D appeals director. If they use a PBM for adjudication of claims and formulary management, then representatives from that organization can come as well. And so we cover, and it usually takes about a day, a full day to conduct the test. We cover a lot of topics. We cover coverage determinations and appeals, eligibility, enrollment and disenrollment reports and processing, claims adjudication, cost sharing, formulary and benefit administration, low-income subsidy, and TROOP. I mean, these are the things that are really going to affect beneficiaries from day one. So again, we're emphasizing that we need to make sure these plans are ready. And so it's collaborative, mostly between my group, Mudbug as we call it, and Jerry's group, the Enrollment and Appeals group, because most of these topics fall into those areas. So what I thought I'd do is just to give you a feel for the essential operations test, to give you a couple examples of the questions that somebody might hear on a test like this. So here, for example, your plan receives a claim in June on behalf of a beneficiary who has been enrolled since January for any particular medication, Detrol, 4 milligrams, we give the NDC, 30 capsules for a 30-day supply. What occurs at the point of sale? So for example, how is it adjudicated and what information is returned to the pharmacy? So then we'll pause and let the plan respond. So we on our side know, is that drug on the formulary? Because again, this is in the fall after all of that information is in the system and set up. So we know the answers. These are clear cut, like so for example, we might provide a drug in that example that's not on the formulary. So we would expect that to be the response. We might ask for the copay or the coinsurance amount that's going to be returned based on where the beneficiary is in the benefit. Another example of a question is Ms. Smith is enrolled in Plan A. On November 12th, she contacts Plan B during the AEP to enroll for a January 1 effective date. Plan B processes her request and receives confirmation from CMS that the enrollment will be effective for January 1st. Then later in the month, she contacts Plan B again to say she's changed her mind and wants to stay with Plan A. What transactions does Plan B process in this case? And then we give some possible examples of what those might be. So you can see that we ask very specific and detailed questions, and I'm very, very happy to report that every plan that's been through this process has passed, which means that it's fair and it works, and that we can ensure that the new and experienced plans are ready to take on their very serious responsibilities come the new year. I think we can move on.
And as I said, I would address strategic conversations in a future slide, so here we are. Back in October 2014, we were looking for a way to address audit common conditions and some best practices across the field. So we came up with this thing called a strategic conversation where the account managers talked to their plans and got feedback, and we found out that this is a good tool for those kind of conversations, and the feedback loops both ways, and that feedback feeds back into even policy decisions and possibly into the regulations. So since that time, we've done about 14 strategic conversations, and it's not just on Center for Medicare issues. We've also worked with the Office of Minority Health to talk about how plans can help address disparate health services in rural communities, and tried to get some feedback on ways we can address some issues in the rural community. We've worked with the Center for Program Integrity to talk about the Plato tool and fraud, waste, and abuse. And so we will continue to use this tool to address not just issues that are specific from this CM perspective, but from CMS agency as a whole, in ways that plans can continue to help us.
So really quickly, marketing is something that you probably all think about as is gearing up about right now, or a little before now, for the annual election period. But behind the scenes, there's a lot of things that go on at CMS to get everything together so you can be ready to market and know what the rules are when you go out into the communities. So in May of each year, you all are probably familiar with the fact that we release those model materials. Well, they're actually, the work that begins to get those model materials ready for release starts back in October of the preceding year. And if it's a year where we need to have Paperwork Reduction Act clearance through the Office of Management Budget, those models go over to them in as early as June of the preceding year. So there's a lot of things that lock us into what we can put into the models, how up to date they are, how quickly we can change them, that happen way in advance of their actual use as a beneficiary tool. In June, we typically try to release the marketing guidelines, although some years we're a little bit delayed depending on the number of changes that we want to implement. And again, we revise those throughout the year. We work with our partners in the Medicare Drug Benefit Group to see if there's any clarifications that need to be made in the guidelines, any updates that need to be done. And we work through the subject matter experts in their group to coordinate all of the Part C and Part D marketing guidelines into one package. In October, obviously, you guys get begin marketing. So hopefully we have the rules out in advance so you know what they are and you can plan accordingly. In November and through January, we work with the folks in the regional offices to conduct retrospective reviews on the annual notice of change and the evidence of coverage to make sure they're accurate and up to date and got mailed to the beneficiaries on time. I'm sure you're all aware of that. And Ray's team plays a key role in helping us through that process. Obviously, that goes on throughout the end of January, sometimes a little bit later. I don't know, Ray, if you want to add anything to that review process.
I don't know that there's really much to add other than what you've said. I mean, we continue to look at materials and monitor to make sure it's meeting the guidelines.
And I think that wraps up with 3 seconds to spare. Wow. So we'll say thank you.
So thank you to the CMS senior leaders for sharing with us the year at a glance today and timing their presentation perfectly. Very impressive. All right, if you would like to evaluate this session, go ahead and select A and hit send, follow the link, and go ahead and answer the questions. Up next, we will hear from both CMS staff and Medicare plan representatives who will provide participants with an understanding of the role of the CMS Medicare Beneficiary Ombudsman and provide opportunities for collaboration. It is my pleasure to introduce to you from CMS, Randy Brauer and Catherine Rippey. And just a note that Catherine is joining us via the phone, so you won't see her face here today. And from UnitedHealthcare, we have Michael Baker, and from Aetna, we have Linda Shoenfelt.
Yay. Good afternoon. I hope everyone enjoyed lunch. I'm Randy Brauer. I am the Director of the Offices of Hearings and Inquiries at CMS. Joining us virtually, Catherine Rippey, the Medicare Beneficiary Ombudsman, and of course our friends from Aetna and United. You'll get to know us as we chat for the next hour or so. I think to just sort of lay the groundwork, what we're really hoping to do today is to begin a conversation with all of you. So the Medicare Beneficiary Ombudsman, many of you likely recall from years past, started around the same time as the Part D program. And what we've taken and done with the Ombudsman world now is to reshape it a little bit to focus more on the experience of beneficiaries in the Medicare program. And when we got to thinking about that, as Catherine's joined us about a year ago now, what we started to realize, and somewhat obvious, but started to realize is, wow, you know, an awful lot of our Medicare beneficiaries get their insurance through a Medicare Advantage plan and or their prescriptions through a Part D sponsor. So our picture of the experience of beneficiaries in the Medicare program is incomplete without all of you. So we started to ponder, well, just exactly how do we start this conversation? And we thought probably the best way was to just ask the question and begin discussing. And so we asked two of our friends to join us here today so that we could begin to talk about the ways we look at the customer's experience, the ways that we measure the customer's experience, what do we do with that information, and then going forward, how do we collectively work together on that very topic, making things better, you know, sharing information, best practices, pitfalls, all of that kind of stuff, without recreating all of the structure that you already have, right? So you don't need another account manager. You don't need another person coming to you and knocking on your door. So it's an interesting question on the how, but I think together all of us in the room and virtually can come up with an answer. So I'm going to stop there and ask the star of our show to please jump in and introduce yourself. Catherine?
Hi, thanks, Randy, and good afternoon, everyone. I regret I can't be there in person to meet with you, but glad to be participating virtually, and just want to say thanks again to Mike and Linda for helping us prep for this, joining us today, and we've had some really good discussion leading up to this session. So as Randy mentioned, we've been, you know, kind of re-envisioning the role of the Medicare Beneficiary Ombudsman to take a look at how can we add the most value to our program and how our beneficiaries experience the program, however they get Medicare, whether that be through our traditional fee-for-service program or through a Part D plan or health coverage through a Medicare health plan. The role, as Randy mentioned, was set forth when we worked tirelessly to implement Part D and all of the Medicare Modernization Act provisions, and really is set up to be an objective, informed source of information for beneficiaries, and also a source of referral. So not everything is answered by me or the folks that work with us, but certainly we are constantly in coordination with our various channels throughout CMS, whether that be our folks at our 1-800 Medicare call centers, the casework and account management staff that I know you're very familiar with. So really working and coordinating and collaborating with those folks that are customer facing, and then of course also our CMS colleagues throughout the Center for Medicare. So just wanted to give you a couple of points about the Medicare Beneficiary Ombudsman, and then we really want to roll into our panel discussion today. But typically, at this point, I concentrate my efforts on a handful of different primary areas, and that includes partner initiatives, so working with a lot of our partners that are working with our beneficiaries every day, like our state health insurance assistance programs. We work very closely with advocacy organizations like the Medicare Rights Center. Also, I focus efforts on inquiry management and taking a look again at all of the channels that we have in place for those casework and inquiry management systems, just to see again how the beneficiary is experiencing the program. Also, of course, there's beneficiary assistance involved. I'm coming to you from Kansas City today. I actually, while I report to Randy in his shop in Baltimore, I'm seated in a regional office for CMS in Kansas City. And that was sort of an innovative approach that Randy and Jim came up with to look at whether or not there might be more opportunities for me to engage with our beneficiary base and the partners that I mentioned earlier. And so far, I think that's working really well. And then finally, we do, out of our shop, issue an annual report to Congress. And so efforts throughout the year are focused on what's going to go into that. I think just a couple of things that are important to mention is that, as the role states, as the Medicare Beneficiary Ombudsman, I really work for our beneficiaries and try to provide their voice back into the various components throughout CMS. I'm statutorily prohibited from acting as an advocate for new Medicare coverage or increased payments. And Randy kind of alluded, we also don't want to or intend to establish a different channel that would circumvent those relationships you already have in place with your account management teams and the staff throughout Center for Medicare or other components that you work with on a regular basis. So just kind of wanted to mention that and echo what Randy said. A key interest of mine overall, again, is looking at how our beneficiaries experience our program. And so that's why we're here today, to begin this conversation, talk about how we can coordinate, what makes sense as we move forward, what should this relationship look like. And so hopefully we'll have some great participation, and I look forward to future discussions. With that said, Randy, I will turn it back over to you to kick off the panel.
Terrific. Thanks, Catherine. And I just want to echo Catherine's last comment there, that it is not only a statutory prohibition, which of course is important, but it's also really just a practical matter that, as the beneficiary ombudsman, Catherine's focus and the focus of the support that others in my office provide to her is around the experience of our beneficiaries in the program and how we can use that information to make improvements and suggest programmatic enhancements. What we can't do is change the law, rewrite the regulations, or amend the policy. So the channels that you have to do those things into the Center for Medicare through your account managers and other things are the channels you should use for that. What Catherine can really do, I think, to be the most helpful in her role is engage with you on how is it that our members, our collective members, are experiencing receiving the Medicare benefits, whether it's through you, through us, or a combination thereof. So to get us started, I thought I'd talk just a minute about, what do we mean when we say experience? So I think all of us could say that in our various organizations, we likely have just reams and reams and reams of data about how many phone calls we receive, how many minutes it takes to answer the phone, how long are we on each call, what's our drop rate, all those things. And that is all very important information that you need to manage a contract and make sure you're being timely and all of that. So not to discount that information, but what it doesn't bring to the table is, well, how did that feel for the beneficiary, for the member, for the enrollee, for the prospective enrollee? And what was their perspective? What were the things they liked, disliked, felt bad about, felt good about? And how can we both learn from the things that didn't feel so good and promote the things that did feel good so that the experience can just be made better and better and better? And so that's sort of the frame through which we're having this conversation at CMS. On the fee-for-service side, one of the things we've done through Catherine was begin an engagement with the General Services Administration and the Office of Management and Budget to begin to bring the skill set more broadly into the agency around journey mapping. So we spent some time learning, Catherine and other folks in our office spend some time learning and training a cadre of folks from across the programs. We had Marketplace, Medicaid, Medicare involved in this work on what does it mean to journey map somebody's experience, and what do you do with that then? So once you've got a picture of what it felt like to achieve X, well, so what? What's the so what question? And that has been a tremendously powerful way to view the world. It's a bit labor intensive, so it's not necessarily something you're going to do at every beneficiary or customer interaction. But, in those moments where that information can be gathered and brought back, you can really, I think, get a picture of what it's like to be on the other end of the phone. A very, very compelling way to see the world. So that's the frame that we'll be looking through, is the experience. And that's one of the things we've done at CMS to start bringing the customer's experience into our world more closely than perhaps it had been before. It's always been a part of the conversation, but we're taking it down to that sort of emotional intelligence level and customer-centric design, which I think is pretty exciting. Bringing that out through all of the great work that I know all of you are doing out there is just another way we can learn more at the agency and we can share amongst each other good things. So I'm going to get us started by asking a question. And so the first question that I was hoping we would talk about today, and we really are looking for some input from all of you, so folks in the room, folks who are virtual, however you can provide feedback, whether that's in the form of questions or what have you, we really do want as much interplay as we can get. But the first question that we really wanted to begin with, I think, is a foundational one, and that is, how are we measuring customer service, or more importantly, the customer's experience? So it's not the number of phone calls, the number of script hits, the number of minutes it takes to answer the line. The experience, how are we measuring that, and how does that feel different today than perhaps it did 2 years ago, 5 years ago, 10 years ago? And Linda, if I may start with you,
Sure,
and then we'll
definitely.
turn to Mike.
So a little bit of a background here. Although I've been with Medicare in the senior market population for a very long time, let's go back to like 1999 maybe, and I thought I was in operations for all those years, and I thought my background was the widget moving and the efficiencies and the effectiveness. What I learned along the way was that what I really loved was the customer service. And so I've been thinking about that for a lot of years. I think what we're doing differently now at Aetna, and likely at other companies as well, the ones that you work for and United, is we're looking at the journey from their eyes. Where we used to look at the journey from our eyes, we looked at the journey from a process perspective. What boat do they step off of? What's their first interaction with us? What's their first claim? How do those things work? And then we measured that process. We measured how long it took, and basically, how do I get them from here to here? And now what we're looking at is their journey, and it starts outside of us. It starts before they ever came to purchase a policy or to sign up with Medicare. It starts before they were Medicare eligible. And so we're looking at, what do I know about a person? What do I know about their background? If I came from a group policy to individual, that already sets expectations in my head for certain things. If I came from, if I had my spouse managing my stuff all my life, and now my spouse is deceased, and this is the first time I'm ever managing my own policy, my expectations are also completely different. My fears are different. So we're trying to get into an emotional heart of where they came from, the context they live in, instead of the context we live in. So, I don't know, Mike.
I think that's terrific, Linda, and I'd love to hear, Mike, what your thoughts are.
Ditto.
There you go.
I'll start with that. I
Conference
think,
over. Good night.
Yeah, we're good.
This journey from a transactional measurement methodology, which you referenced, and looking at the journey is, I think, not just what is evolving right now in the healthcare space, but we're seeing that play out and has done so, I think, more effectively in past years in the retail space and the financial services space. And I think we're learning some of those lessons. The work that we do matters a whole lot more than retail service or financial services type customer experiences. And I think Linda referenced it best, and that is, what does the entire journey look like for the human being through their eyes? And I think in the healthcare space, as we've started to consider our role from that perspective, we've become a lot more effective at what we do. You mentioned transactions, and look, I'm an operator by trade, and so if it can be measured we measure it.
Right.
But there are a few measures that we found that are much more profound and much more valuable, and not because the measure itself is significant, but because it leads to lessons that help ferret out the issues that are inherent in this environment that Linda just referenced. For us, now that's Net Promoter Score has become that primary measure. Net Promoter Score, for those less familiar, is a very simple measurement process, and most everybody here has been asked the primary Net Promoter question from someone with whom you do business, and that is, would you recommend UnitedHealthcare, Delta Airlines, whomever, to your friends and family? And then you take the people that give you a 9 or a 10 on a 10-point scale, subtract the 1 through 6 on that scale, and that becomes your Net Promoter Score. But more importantly, the people that give you a 1 or a 2 or a 6 or a 10, why do they do that? And what is special about those demographics from their perspective? And that's really where we see ourselves going now.
That's really interesting. So, thinking about the tool that you might use right now, that's a good example, I think, Mike. But Linda, when you think about getting into the emotional quadrant of what people are experiencing, what are ways that you try to capture that information, understanding that we have boundaries, right? I mean, we don't have unlimited money and time to spend with every single person over a cup of tea,
right?
But so what do you think along those lines?
So a couple things that we're doing and others could do as well, or maybe already are doing. When we train our customer service reps, and we train them with this emotional heart background that we have, we're not training them in just how to answer the phone, how to look up something in the system, how to perform a transaction. We're teaching them to be investigators. We're teaching them to dig deep into why that person feels the way they feel. And then we're capturing kind of a scoring model that says, if they've called us X number of times, if they've had this many claims, if they've filed a CTM before, if they've had multiple grievances before. And that with the Net Promoter Score, we kind of take all those things and bundle it together. And then we do surveys also of the service they have from the reps that have the new kind of training, different from the reps that maybe haven't been inculcated in that yet. Or the new hires that were coming on board, we're bringing that training in up front. Those that have been with us for a while, we're back kind of filling that. And it's interesting, but when we do the surveys from those folks that had someone that went through the emotional heart kind of training, they all, both sets of surveys usually say, your rep did a great job, she answered my questions. Some of them say, I wish you would have paid my claim differently. Right. But the folks that have been through the emotional heart will usually tell you, I really felt like the person cared. And we actually capture these scores. We look at the scores of the folks that have been through these surveys and haven't, and we see, are they going up? Is the training that we're providing and the lesson that we're hoping they take with them, that they see that person as a person? So we add the Net Promoter Score to our quality survey scores. And then we have focus groups that we reach out to. And we've passed things through them that say, if you were handled this way, if you received communication, a lot of work we're doing is also the communication and the education side, beyond our commercial handling process, if you will. If you received this piece of communication, do you understand it? And we're changing how we write and how we put things in their context instead of ours, and then we measure the impact of that.
That's, fascinating. I'm sorry, Mike, did you want to?
Jerry Mulcahy said in the last panel that we're only bound by our imagination and our budget. And I think that goes the same for those of us in the private space. But I just want to double down on what Linda said in this idea of how you train. And I'll add to that, who you hire has become really important for us. And I was asked at lunch today, we have both a seasonal hiring process and then a kind of a regular hiring process. But what is it you look for in an advocate in our frontline teams? Our folks are referred to as advocates. What do you look for in an advocate? And for us, we've really evolved our thinking in that space as well, in that now we look for two things primarily. It doesn't matter if they've ever worn a headset before. We don't assess their typing skills. There are two things that we look for, and the first is compassion. And they may have demonstrated compassion in any role that they've had. It could have been as a volunteer at the Humane Society, or they could have worked in a nursing home. And then the second is tenacity. We try and measure grit and determine that they will use that compassion and that heart that we hire for, and then the personality traits that are inherent in somebody that will grab onto an issue and not let go. Mm-hmm. And the combination of those two factors for us is the right foundation from which we can do the kind of training that Linda mentioned so well.
Right.
I love it. So Catherine wanted to ask for your thoughts in this space. And one of the questions that I have, I'll start with you, Catherine, and loop back to Linda and Mike here is, there's a couple of things that come to mind for me. The first is, and we're going to talk a little bit more about education because it is an enormous part of this, but as you begin to become familiar with the different experiences of your different customer bases, it becomes apparent that it isn't necessarily a one-size-fits-all. But being bound by our imagination and budget, mm-hmm. we can't necessarily have 75 different ways to say something. So curious if, how that's been playing out as you're looking to evolve messaging. And Catherine, in your space, how you are interacting with so many different groups who have a very different focus on, what it is that's important to them today. The beneficiary community in Iowa is not necessarily concerned about the same things as the beneficiary community in Manhattan, nor are the advocates that represent them and other things. There's some foundational truths, but I'm sure you get the difference there. So I'm curious, in that space, what's the balance, or I suppose you find it over time. But so, Catherine, any thoughts to share with us?
Well, I think that's a really important consideration. You mentioned the geographical differences, that we might have with beneficiaries residing in a rural area, or even not rural, but a geographically isolated area, versus those more metropolitan, dense communities. I think that's a place that we've really started to look at. One of the things that we're part of here is the Rural Health Council that's taking a look overall at how we as a program target messaging to those communities and how that differs from some of the other messaging that we might use. That's one example. I think the other thing that we're really thinking about is how different our Medicare beneficiary bases are becoming. Those of our folks that may have been with the program for quite some time and are used to traditional fee-for-service Medicare, and how they engage with us is very different from those that, and Linda kind of alluded to this before, the journey starts long before they get to us, and how different the health insurance landscape is today, the different types of products that they may be used to in their working lives, and then transitioning into retirement and getting covered under Medicare is very different for people aging in today than it was even 10 years ago. So I think what we're trying to do, Randy, to kind of get at your question, is look at those different experiences. And you alluded to the journey mapping process that we went through and the training that we went through, and we really hope to expand that so that we can take a look at the different customer experiences and determine from that, are there ways that we can message? Again, we know we can't target a message to every single, individual type of population, so we keep that in mind. But are there specific groups that need a special type of communication? So definitely something we're engaged in and hope to be making some improvements in moving forward.
Great. You guys have any thoughts?
I'd just add that you mentioned a rural Iowa beneficiary versus a Manhattan beneficiary. I would also suggest that the difference between, if you look at the landscape of members that we serve, it's not just geographic differences, obviously, but there's a 47-year span between somebody aging into Medicare and the oldest members that we serve, yep. And that obviously excludes those on disabilities that are on Medicare much earlier. And so that distinction, I think, is also really profound. And then couple that with the difference between a beneficiary who has a disability and perhaps multiple chronic medical conditions and somebody who participates in Ironman triathlons. Their needs are going to be very distinct as well. And I think the real value that we'll be able to bring to beneficiaries is in recognizing them as individuals. And that's not just how they wish to communicate with their health plan or with their provider's office or others, but the kind of support and care and, frankly, plan design that they need from all of us. And how well we recognize that and then tailor an experience unique to them, I think will be one of the most important judges of our success going forward.
I think, I noticed earlier we were watching the presentation on the encounter data, and I started in claims a million years ago. So I was sitting there and somewhat engaged, and maybe others who didn't have that background were not quite as engaged in encounter data. But we're using big data, and I saw the word up there. We're using big data differently. We're not using it to look at our transactions. We still do that, of course, but for our member experience, we're looking at it from the front end of the sale, from the needs analysis component. We're looking at pulling in not only those cultural things, which also are geographic in some nature, but the social determinants of health. What in a region has a certain population that has a different need? We're taking all of these components together, a lot of analytics, a lot of crunching to say, who is this person that lives here? I could be a transplant from New York to Florida. I could be fleeing in a hurricane right now, and I commented on the plane, there were 17 wheelchair-bound individuals. They were moving from a nursing home on my plane. Wow. And people were complaining in line behind them because they got to get on first, and now they were longer in the Southwest line, and their letter didn't matter as much. And I thought, you've missed the point.
Oh, wow, yeah.
And so, it's our job to use all the information that we have. That big data on the social, on the cultural, matching them to the right plan. Like Michael said, we talk about service on the back end, but if they ended up in the wrong place on the front end, your service just got a whole lot harder.
Right.
And so, how do we match them? And one of the ways is we have to know their perception of the world as well as our reality. What do they think they need might not be what they need. But at the same time, if we don't pull that correct information out, if we don't educate them, helping them, it's a complicated business. And we tend to want to educate them the way we think they need to hear it. And you comment looking at the millennials or looking at the different generations that we have. I speak network. My mother speaks doctor.
Right.
I speak plan benefits, and she says, "Are they going to pay my claim?" And turning that around to their perception is really how we'll get through.
Makes a tremendous amount of sense to me. Of course, the challenging part is the how.
Mm-hmm.
And how do you make it real in your organization? How do you share that information backward in? So Catherine had mentioned one of her key roles is to, hear from the constituency writ large, separate the wheat from the chaff, and bring back the wheat. What is it that we can actually share with the policymakers, our friends in CM hosting today's conference, and other things that adds value to the conversation, but isn't to the point where 60 million people on Medicare, we can't have 60 million flavors.
Mm-hmm.
So it's a little bit of a tricky balance, and I just want to put a plug in for our friends here in the room as well as our virtual friends that your ideas are welcome like this. I really do want the conversation to start today, not end today. Mm-hmm. So how we continue to do that is a story yet to be written. But I very much encourage you to, if you have thoughts, ideas, concerns, questions, drop them. We likely won't answer them today, but what we can do is collect them and begin to the second leg of this never-ending conversation. Before we move to education and outreach, though, I wanted to just pull on data a little bit more. And when we got together and talked before today, one of the things we really wanted to touch on was what are some of the creative ways that we're collecting this information, and what do we think that might be evolving into? So just as an example, we know, of course, in our space and obviously yours, that Medicare beneficiaries who are aging into or otherwise becoming entitled to Medicare now are much more likely to be technologically comfortable and savvy. And they're looking for things like apps on their phones, and not everyone, of course, but a much greater proportion of folks coming into our programs now share that trait versus when Part D launched in the first place and people thought the internet was the great evil and all of that. So, thinking about it along those lines, what kind of innovative things, if you guys can share some examples with us, are we doing to find and collect this data in a way that's efficient and cost effective? Because again, we all have a budget to live to, but that brings back some of this value. And where do you think that's going? And Linda, we'll start with you.
We've got a number of focus groups that we've been working with. Kind of an interesting concept, but a lot of them that are retired at home with not a whole lot to do love to talk to you. They want to give you the information.
And they all have my phone number.
Right. And we'll get them on a panel. We'll ask them, if we could make this better. We do a lot of before and after. So we were recently working on revamping some things on one of our websites. And we presented the website the way it exists today. And we got a bunch of feedback from them. And then we presented another iteration, and we mixed it up with half of the same group that had seen the first half, and some new people that had not seen it yet. And then finally ended up in like a last iteration. Now, not only did we get data from them, and did we get information, and the group was mixed, age mixes, location mixes. We let them do it online. We have a program, and they can answer the questions and talk real time with us, et cetera. But what was interesting about it is, depending on what region of the country they lived in or what age they were, we got different answers. So then they would actually, kind of argue with each other. No, that's not the way I would put it. No, that's the way I would put it. But in the end, what we got is a group of people who thought they really care because they're asking. So that's one of the ways that we found you have to talk to them and you have to listen to them, and we're trying to capture those things in lots of mechanisms. But
our customers, our beneficiaries, our members get all the votes, and so we should ask. I mean, I think what Linda referenced is the single most important thing you can do. Another thing that we're trying to do is start with health outcomes, and whether that's at the population health level or at a specific segment level, and then work our way back into an understanding of what led our members, our beneficiaries, to that place. And so a positive health outcome had a journey that came before it to reach that outcome, as does a negative outcome. And what does that tell us? So as we walk back through that journey that the members followed, were there transitions from inpatient facilities? Was it preventative care? What was it that either resulted in a negative outcome or a positive one, or somewhere in between? And how can we learn from that and then apply those lessons to the work that we do every day, whether that's in the service environment where we live, or the health plan design, or how we partner with providers and the like. But it all starts, I think, with asking the people we serve, Linda, and you said that well.
I could not agree more. And Catherine, I don't want to leave you out of the discussion. I think in our space, like all of it, United, Aetna, enormous organizations, and Medicare's not your only line of business, and that's also true for CMS. Medicare's huge for us, but it's not our only line of business. We have a lot of initiatives in that program, but also other programs, obviously Medicaid in the marketplace and other things. And so, one of the things that's been somewhat interesting, I think, and Catherine, I'd love your perspective on this, is where those waters collide. So, we've had some conversations around where individuals who are enrolled in marketplace plans find themselves newly eligible for Medicare, and the challenges that sort of thing can bring. And I'm curious, Catherine, any thoughts from you on that? And then to our plan friends here, if that's an area that you found where seeing the emotional impact of what's happening to someone is a bit more apparent, because that's been true on our side. Like, it was a bit more obvious in these situations. Catherine, any thoughts on that?
Yeah, you alluded to it, Randy, but I think, and you used Medicare and Marketplace as an example. I think transitions in general is a really big area that we can perhaps focus more on, making those transitions from retirement coverage to Medicare, or I shouldn't say from active coverage to Medicare, retirement coverage to Medicare. Also the transition just within Medicare. I mean, I can remember early on, more so than now, I think, people assuming all Medicare was all Medicare, and so if they had an original Medicare plan, or original Medicare rather, with a Medigap plan, and then they enrolled in a Medicare Advantage plan, they naturally thought that the Medigap plan would terminate, resulting in, double coverage and payments, until they realized that wasn't actually the case. And many times I can remember speaking with beneficiaries who said, "You're all Medicare, you're all one," And so I think about that with Medicare and Marketplace as well. We do have different lines of business. The plans, obviously, as you mentioned, do as well. But how are we really preparing the individuals for that transition from one product or plan to another, or one stage of life to another? And I think that's something that we've already started to focus on with Medicare and Marketplace specifically. We also, have been looking at, are there ways that we can help people who delay past 65 transition into Medicare better, or easier, or simpler? Especially one thing that comes to mind, and that not necessarily always going retroactive with Part A, because they may have been contributing to a health savings account. So I think as we talk with our beneficiary base and we hear some of those challenges, we're at a key time to really look at how that landscape has changed. Again, as I mentioned earlier, when I started with Medicare 11 years ago, the sort of tagline was, take Part A at 65, it's free for most, even if you're going to continue working. And we know with some of the implications of HSA contributions and whatnot, that isn't the one-size-fits-all answer anymore. And I think, we have to take a step back and look at all those different journeys that people have been on.
Folks, anything to ponder on here?
Catherine referenced transitions a couple of times, and I don't think you can emphasize that enough as a problem spot. And so I'll come back to that, but I think on the topic of education more broadly, I think we all have a responsibility to help at an aggregate level those that are joining Medicare for the first time, or are participants but about to experience some kind of change. United's Medicare Made Clear program, I think, is one of the programs where we help to do that at a broad level. But once you are in the system, so to speak, and you encounter those experiences, and transitions is the perfect word, because it's the most problematic place, in my experience, that our beneficiaries find themselves from time to time. And it's not just the health or financial consequences of whatever that transition is, it's that they don't know what to expect. And fortunately, we do. And so a member of ours that hasn't had, let's say, a cancer diagnosis ever before, or any kind of significant illness diagnosis, doesn't know what to expect, doesn't know what comes next after that, but we do. And so how we not just educate them about what the condition means, what's going to come next, but how we hold them by the hand and guide them through that process, I think, is what education really needs to be about. And that's a very personal thing for our members.
Right. Yeah, and I'll add to that, we talked about transition, of course, again, really big word. We talked about the journey. And so you're pointing out a piece in a journey where something new happens for the first time that's never happened before. We look a lot also at the expectations they have, because they have a preconceived notion of something that has happened in their life before. So when you kind of started out, Randy, talking about, maybe they come from the commercial world or some other place and they're moving over to Medicare. One of the things that we're doing with our education programs is really trying to bucket the difference. You can't do all to everyone, or one size fits all, or too much regional. But you can, in the 5 or 6 buckets, I've never had insurance before. I've had insurance in the commercial space, and I'm moving to a group. I'm moving from group to individual. I'm moving from original Medicare plus MedSup to a Med Advantage. And so it's setting the expectations for what will happen and how it will work, which is different than setting the expectations for what are the plan benefits. Right. And so, you know, if we're going to tell somebody, okay, you moved from, and this is a original Medicare plus MedSup to a Med Advantage, what will work differently? You know, we as Med Advantage, we will handle all your claims. Before, your original Medicare handled these claims, your MedSup handled these claims. What does handling a claim mean? We've even gone deeper into saying, what does it mean? Will I send it to somebody different? Do I need to do something different? Will my provider know what to do with me? Are they going to have my old card on file and think I still have the same insurance I had? So it's us, really, a lot of what we're writing today in our educational materials and in our letters and things that we're sending out, you know, post-required materials, but more educational, et cetera. We're honing in on actionable efforts. What do you need to do, and what do we need to do for you? And really helping to drive, telling them that ahead of time, as opposed to having them read it and say, well, what about this applies to me? So a lot more personalized, not that we can personalize everything to every individual's circumstances, but we can at least personalize the big buckets. You know, have they had a lot of medical conditions? Do they have comorbids already existing? Are they the typical COPD, diabetic, you know, obesity candidate, and we know what's going to happen next? Right. And how do we help them help themselves? But how do we also do some of it for them, like you said, walk them through it, hold their hand? And of course, that's back to the whole budget conversation that we started with. You know, where's that balance? Right. But I think the more we do for them up front, the less it costs us on the back end. In the end, you kind of got to balance that.
I would add to that I think a better experience as an enrollee of a health insurance organization, whether it's Medicare fee-for-service or any one of our plan organizations, will hopefully result in more engaged customers who can then be better participants in their own healthcare, right. Hopefully then taking us down the road to better outcomes. That's a little bit of a stretch, but I think it's true.
I do too.
Yeah, totally.
Well, if I can jump in,
Please
too,
do.
that I was just going to say something like that, Randy. You know, an important part of us looking at that education, and I really appreciate what Mike and Linda have mentioned and brought to the table. I'm over here taking lots of notes, but I think that the whole idea of helping our beneficiaries be their own advocates as well. I mean, we always are going to strive to help walk them through the process when they need it. But what a great thought for us to have of moving towards promoting that education to help empower them as patients as well. And I think that's a really important piece when we look at the experience overall.
I couldn't agree more, Catherine. And, you know, Linda, something you said really resonated with me, and that was the what's next. You know, I'm used to sort of the plain language approach to materials, which we all know and love. And I understand, of course, the need for that. But often what seems to be missing is that the point is buried somewhere. You know, I'm the kind of guy I like to see tell me the bad news up front, whether it's good or bad, doesn't matter. Tell me the news up front and tell me what I have to do next. What should I expect next? And I think a lot of our materials, you know, I'll speak just for myself, from the Offices of Hearings and Inquiries, tries to get there, but I'm not quite sure that we're there yet. But anyway, that's, I think, a real takeaway for me is we can reduce the number of times people need our customer service assistance if we can help them see the path forward a bit more clearly, help them know what to expect and manage that expectation. Right. Thinking about the perceptions they come to the table with, thinking about the baggage they're carrying, and that I don't mean that in a negative way. We all have baggage. You know, that's a real takeaway for me. Michael.
I mean, in our line of work, we say that the best service is no service.
Exactly.
And we should work to that end. And you know, you reference material and both complexity of it and volume of it as a challenge. And you know, my mother is a customer of ours, and she lives in Arizona. I live in Minneapolis, and I'll come and visit my mom, you know, 3 or 4 times a year. And whenever I do, she'll pull out this big box, and it says, it has a marker. It's written with marker on the side, letters from Mikey. Even though I mean, it's anything that comes from the healthcare system or letters from Mikey. And so we'll sit down and we'll look through all of this material, and you know, we've got 5 degrees between the two of us, and And it requires every one of those to really understand what we're doing.
Indeed.
Yeah.
And that's a tough nut to crack, because the balance here is the requirements that law and rule and other things place on us to make sure people are fully informed with getting the right information to the person at the right time in the right way. And that's a trick. I don't know that I've perfected it, but it's definitely worth continuing to talk about.
Yeah, and just want to add in, because you guys reminded me of it while we're sitting here talking, is the caregivers have a big component in this too. Yeah. You mentioned yours. I have my 2 elderly parents. They have group insurance. That's even different. And I'll get the phone call or whatever. Or I get better ones. My friend at bingo has this question for you. But the caregivers are the people that also have set expectations. If your caregiver is a younger adult to an older parent, they haven't experienced Medicare at all either. So now we've got to get them educated, and they've got to read so that they can explain it to someone else, because that someone else is who they're trusting. They trust their provider, their children, their parent, their grandparent, and those are the folks that we have to reach as well. So that's one of the other avenues that we're spending a lot more effort thinking about.
Wonder how and to what extent, and this is out of left field, we haven't talked about this before, but as I'm listening to you, I'm thinking to myself, obviously in our line of work, the hands-on touch is almost always the provider. We're at a distance. We're by the phone. We're by the internet. We're by correspondence, generally speaking. How, any creative thoughts or things to think about in relation to that, getting the provider as part of this conversation. Obviously, a busy doctor's office doesn't have time to just be a UnitedHealthcare expert and an Aetna expert and so on and so on and so on and so on, as well as Medicare generally. Thoughts? Things you've run into there? Problems, issues, concerns?
I think if there's any 2 things that to me feel like really unmet needs of the population that we serve, it's the caregivers that Linda mentioned, and Randy, I think it's the partnership and how we collaborate with the providers whose patients we are jointly serving as well. And I agree with you. A doctor's office, particularly one with some volume, has no ability to be an expert in UnitedHealthcare and Aetna and others, but they shouldn't have to be either. Right. They should be focused on what they do best, which is taking care of their patient, and how we empower them to do that, and then orchestrate the relationship that particular provider has with, let's say, specialists, and then even other complications associated with healthcare, like the economics of healthcare and how payments are made, et cetera, and how we can orchestrate all of those for me, and do so with a relationship with the provider community that is not an adversarial one, which is, I think, maybe how it's evolved a little bit in the past, or how it's been perceived in the past, but how truly as partners in the health of those that we jointly serve, and how we can make that work better, coupled with support for caregivers, are really the 2 uncharted kind of needs that we have.
Right. And I think, my operational hat comes on first and thinks, how did we do this years ago? And the sentence I always used to use is, incentivize the behavior you desire. And so we have some incentives that way. We have some incentives for, accountable care organizations and other folks to look at care differently, or to spend more time with the patients. But I think part of it, I'll take back to even the big data piece. They shouldn't have to know all the details. They've got to check eligibility. They've got to make sure they have the patient with the right plan. And after that, we need to make it much easier. Now, I know we have, industry-wise, we have some real-time claims adjudication. You can go to the counter and certain things can be automatic on a phone, et cetera. I think we're moving to a lot of digital abilities that make it easier as well. Today years ago they used to take the picture of your card and you waited and they went to the copy machine and they put it in. Now they run it through some little machine. Now they want it on your phone. And so the more advances we make to make those things smoother and less, need for them to know every detail, hopefully what they'll do is spend more time with the patient, our member, our customer, and less time and advocating for us as their plan or their coverage or their carrier, as opposed to, having it be an uncomfortable thing to have to file a claim. So I think there's still room there for us to build, and I think we are, as an industry, moving a lot toward different provider relationships and collaborative agreements, et cetera. But I definitely think there's room to grow there.
And imagine what it'll be like when we do that, right?
Yeah.
And the unique position that we are in to provide decision support tools to not just the patients, again, that we jointly serve, but to the providers to help them, position them to make better decisions on behalf of those they serve is a really powerful thing. And you don't do that unless you've got a collaborative, trusting relationship, which is built exactly how you just described it.
Well, I can't thank you guys enough for this. I'm going to bring us to a close here as we've only got about 6 minutes left, but I wanted to end with one sort of open-ended question to everyone, to you in the room, to all of us virtually, but specifically to Mike and Linda, who I am so grateful you could come and spend time with us. Linda, especially because I know you came in from Florida, God willing, so get home and be safe, please. But the question I wanted to end with is really, so what? Like, we had this conversation. I love this stuff. You know, I get very energized and excited about it. But where do we go from here, thinking about the relationship between the Ombudsman and that service that my office and Catherine provide into a relationship with the health plans that survives in the environment where you can call me and tell me you don't like, you know, how something's calculated, but there's nothing that I can do for you about that. So better that we have this conversation. And so any thoughts on, you know, what's the path forward? And this doesn't have to be, guys, like a set in stone that we shall do it this way and no other way, but rather thoughts and ideas, creative thoughts, things from all of us virtually and in the room would love to hear. How do we keep the conversation going? Sharing this kind of information with one another, sharing the things that concern us. Thoughts?
Well, it kind of reminds me of a CMS demonstration project. You know, a group of people that care enough to start the conversation, find a topic that they really think needs opportunity and change or is a challenge. I mean, the key things that we talked about, if you think about it, communication, education, and really members' perception versus our reality. You know, you build a strategic partnership, some sort of demonstration project where we really look at those three buckets. Maybe we pick one like communication, and we say, okay, you know, every letter we have out there, you know, let's pick the top 10 that cause the most complaints or the most misunderstanding, and we're doing this at Aetna. So we've already, you know, begun our reviewing at, you know, what pushes a button that every step along their journey, where can we communicate resetting an incorrect expectation or an expectation we didn't even set, which generally does happen. They came with it. It's a preconceived notion of how it was going to work, and we didn't even do it. And you know, maybe partnering with your teams to look at where also, you know, model language and other things that we have out there, where we can help tell the story collectively better. And the same story where it is the same.
Right. Fair enough.
Three things. The first is ditto what you just said. And the second for me is, you know, I think the role of the Ombudsman can be one as the kind of clearinghouse for collaboration. And I think that's a real opportunity that we have collectively. We all serve the same people, and it's my mother, it's your mother, and the extent to which we can do that better together, a rising tide lifts all boats, and we're all you know, paddling
Careful
in
with
the
the
same
boat
boats.
jokes.
So, well, you would want to be in a boat, I presume. This is the alternative. And so that collaboration, I think, to me is critical. And I think the other thing is, and this is less about what we do as an industry, but more as leaders in the healthcare space, and that is, I think we need to throw out the rule book generally and think about the way we serve people, not in as Aetna compares to United, as compares to fee-for-service. I think we need to ask ourselves, through our customers' eyes, which we've been talking about this whole hour, they don't compare Aetna to United. They compare United to DirecTV and Apple and the other people from whom they experience a product that they feel is important to them. And I think that's how we need to look at this space as well. And you can't do that if you are bound by all the rules you've always lived by and the norms that you've grown up following your entire career. And I think as leaders, it's up to us to not do that anymore.
Yeah, absolutely ditto, Michael. Absolutely. Our
Well
distribution, said. Our mechanisms, everything that we do, we can look at it all as a reinvention. Amazon does that, and a lot of other companies that you just referenced, they're constantly looking at new mechanisms to really be what that member needs them at the point in time they need it.
Agree.
I mean, it's the goal I think we should all be aiming towards, and I hope this is at least a first step. And in the interest of education, my friends in the Office of Communication asked if we would share some information with all of you about the New Medicare Card, New Medicare Number project, which I'm sure you've all heard of, previously known as the Social Security Number Removal Initiative. It has been rebranded into New Medicare Card, New Medicare Number. Don't ask me why, it just has been rebranded. But at any rate, I think you've all been made aware of this, but starting in April, right, so not far away anymore, we will begin replacing everybody's Medicare card. And it's not just a new card, it is a new number. This is a new paradigm for our Medicare beneficiaries because most folks have become very familiar with their own Social Security number or that of their spouse. But of course, the obvious and important reasons why this must be done. Not only was it something put into law, but it's it's just a good idea. People's Social Security numbers shouldn't be in their wallets. One of the key important things that we are trying to do here and want to encourage you all to be a part of is helping our customers not be afraid of this change and letting folks know that they need to make sure that they have their address up to date at the Social Security Administration. It's at SSA that the address CMS uses comes from. If the address is wrong with SSA, it's wrong with us. You all know this from state and county code days for those of you back in that joy. So that's a very important message that we're encouraging members to do. Please do make sure that your address is accurate so that we can get a card to you safely. People will be told, this is an important one as well, that people will be told to begin using their card immediately upon receipt. So, in the background, what's happening here is that everyone's new Medicare number already exists. That work is done. We just haven't flipped the switch because, we need to get those numbers out into people's hands. The minute they got their new card, they should begin using their new card. And we want them to destroy their old card. That's the red, white, and blue card with their Social Security number or the Social Security number of someone in their life. Here's a place where you can be helpful, though. What we don't want them to hear is they should destroy their health insurance card because they're going to throw your card out. So, you can help, I think, encourage our folks to know what it is we're talking about when we say your old Medicare card, that tattered up, used to be red, white, and blue. Now it's kind of yellow, red, and blue. That's the card you can let go because you'll have a new card. There's lots of information online. I hate people who read web addresses, but the good news is this is a simple one. Just go to cms.gov/newcard, all one word, NEWCARD. Lots of good information there, and you can always send an email if you've got questions or things you want to make sure folks are thinking about here as the project continues. And the address there's irony in this. You ready? It's SSN removal. Come on, that's funny. We just rebranded this, but the email address is still ssnremoval@cms.hhs.gov. So please do, if you have concerns, send them through there. You can always shoot it to me and I'll get it to the right place as well, whatever works for you all. But in any event, wanted to share that public service announcement and say thank you to Linda and Mike for taking the time to have this conversation. I hope you guys thought it was interesting. I know I do, and I hope it's the beginning of a lot of conversations. We'll figure that out. Love your input, love your thoughts and ideas. Catherine, thank you for joining us virtually. I don't think we've actually got time because I bled over by a couple of minutes. So I'm going to say we probably don't have time to take a question from the audience, but I encourage everybody, if you had a thought, concern, question, something you liked hearing, something you didn't want to hear, please share that through the feedback mechanisms our wonderful conference coordinators have put together for you. And that's it. I'll stop.
Okay, I just would like to add that at the end of the day, we do have an open Q&A, so if you do have questions for this group, you will have an opportunity then to ask them. So at this time, I would like to thank our panel for the discussion on how we can coordinate and improve the Medicare beneficiary customer experience. So thank you. All right, it is that time to evaluate this session. If you would like, go ahead and select A, follow the link. We are also going to be taking a quick break, so please return promptly at 2:30 for our next session. And remember, for our virtual audience, if you have questions, please send them in at this time. Thank you. Welcome back to those of you here in attendance with us, and also those of you still watching via webcast. We thank all of you for being back and being on time. Just a couple reminders. If you have questions, those of you on our webcast, go ahead and send those in via the SurveyMonkey link. We will have that open Q&A session at the end of the day where you can ask any of your questions that you did not have an opportunity to ask earlier today. Also, if you would like to provide feedback regarding today's event, a link to the event survey will be emailed to you at the completion of this event. And please consider taking a few minutes to provide CMS with your feedback. Our next session features a discussion with representatives from CMS who will provide participants with a better understanding of what constitutes an appeal, grievance, or complaint. It is my pleasure to introduce to you Coretta Edmondson and Paul Collura.
Good afternoon. My name is Coretta Edmondson, and I work in the Division of Appeals Policy within Medicare Enrollment Appeals Group. Our division is responsible for developing regulations, policies, and procedures for Medicare C&D for initial coverage requests, appeals, grievances, and other processes resolving beneficiary disputes. Audit findings have shown that the misclassification of initial coverage requests and appeals and grievances continue to be an issue. Today's presentation will cover the appropriate classification of Part C and D requests for coverage or appeals, grievances, and complaints. It will also cover the effects of the misclassification and the appropriate handling of CTM complaints. A complaint may contain a grievance, a request for coverage, or appeal, or both. All issues must be reviewed by plans on a case-by-case basis to determine how they should be categorized and processed. If the facts of the issue do not clearly indicate that the complaint is a grievance, the plan should process as an appealable issue. Let's start with coverage request and appeals. A coverage request could be a request for a coverage determination or an organization determination from the enrollee, their representative, prescriber, or provider as it relates to a payment or for provision of an item, service, or a drug. If the enrollee disagrees with that coverage or payment decision, they can appeal that decision. They can appeal it as it relates to the service, item, or drug, as it relates to the payment, or as it relates to the cost share that the enrollee was required to pay for the service, item, or drug. The next slide shows examples of coverage requests. For example, the enrollee may call the plan and say that my pharmacy said that you won't pay for drug X, but I need it. Please remember that enrollees may initiate the coverage determination process. A plan may not say that the prescriber is required to contact the plan. Another example could be if the enrollee calls and argues that the drug should not be excluded for the particular indication for which it is being prescribed. For the Part C side, it could be that the enrollee has been seeing a particular specialist for a while and calls and is upset because the specialist is no longer contracted with the plan, and he or she wishes to continue care with that provider. This would be treated as an out-of-network request for coverage. Another example would also be a dispute over cost sharing. For example, it could be a direct member reimbursement request for a Part D drug. For appeals, if the enrollee calls and says that I want to file a complaint, you have denied my request for drug X or for service Y and I need it, remember, if the determination has been made and the enrollee is disputing that determination, it can be treated as an appeal. Therefore, the appeal should be started unless the health plan or the plan sponsor does not accept oral standard appeals. They must inform the enrollee of how to submit a written appeal request. We will now have our first polling question. An enrollee calls the plan and says that he or she is upset because the pharmacy would not fill his or her prescription because it requires a prior authorization. How should this be categorized? We'll give it another moment. Okay. This request should be categorized as a coverage request. Please remember the enrollee may initiate a coverage request. If it was rejected at the point of sale, the pharmacist is required to give the pharmacy notice, which indicates how they may contact the plan to initiate that coverage request. Once again, I cannot say enough that the prescriber is not required to contact the plan to start that process. And of course, these requests must be, the decisions must be made within the required time frames, depending on the type of request that is in fact received. Is it stuck? Sorry. We have another polling question. If the enrollee calls and said, you denied my request for home health, but I need it because I cannot leave home, how would the plan classify this complaint? The answer would be C. This would be handled as an appeal. The request has been received, the plan has already issued a denial, and should have provided appeal rights with that decision that was issued. So again, it would be handled as an appeal, and if the plan accepts oral requests, then they would start the process immediately. If they don't accept oral requests, they must notify the enrollee or the appellant that the request must come in writing. Now we will talk a little bit about grievances. A grievance is a complaint or a dispute brought by an enrollee or their representative that is not a request for coverage. A grievance generally is a complaint regarding the services or benefits that are provided, or it could be a concern about the operations or activities of a particular plan. Grievances may be filed verbally or in writing, and plan sponsors or MA organizations may realize that a large percentage of grievances are submitted orally, and even in some cases may be resolved within one phone call. There are no appeal rights with grievances, and sometimes, generally, a longer time frame to notify the enrollee or the representative of the resolution when it comes to grievances. This slide contains examples of grievances, which could include the enrollee's involuntary disenrollment that is initiated by the plan. It could be they're complaining about the change in the premium or cost sharing from one contract year to the next. Maybe it's regarding difficulty contacting the plan, the appeals process, or it could be a general dissatisfaction about a copayment amount, but they are not disputing the amount that he or she is required to pay. We will now go out to our next polling question. A plan has received a complaint from a beneficiary about a change in his or her premium. Within what time frame should the plan respond to the complaint? This is a grievance, so therefore the correct answer would be 30 calendar days. Please remember that all issues that are discussed within the grievance must be addressed in the resolution. And again, they must be responded to within 30 calendar days. There may be instances where multiple complaints are discussed in the same phone call or in a letter. If the enrollee raises 2 or more issues, each issue should be processed separately and simultaneously to whatever extent possible under the appropriate procedure. Therefore, if there's a grievance that's submitted along with either the appeal or a coverage request, they must be handled separately but within the appropriate time frame. For example, if there's a grievance, you do have within 30 calendar days to respond. If it's an initial coverage request for, say, a Part D drug and it's standard, not an exception request, you have 72 hours. So please make sure all of the issues are resolved within the appropriate time frames. Our next polling question is, a member complains that he or she had to wait so long for a service or a Part D benefit that he or she went out of network. How should this request be treated? We'll give it another minute. The correct answer would be both. The fact that the enrollee had to wait so long for service, that would be treated as a grievable issue, and if they went out of service, out of network, or out of the area, out of network, excuse me, for the benefits, that would be treated as a coverage request. This next slide provides you with another example of what would be considered a grievance as well as a coverage request. For example, if the enrollee has a benefit that covers 1 pair of eyeglasses every 24 months with a max contribution of $70, but the enrollee believes that the glasses are no good and that the prescription was wrong. The enrollee is requesting that the plan cover another pair of glasses where an enrollee complains that the previously rendered services are inadequate and substandard in quality. This would be classified as a grievance. It would be a quality of care complaint. And the request for a new pair of glasses is considered a new coverage request. The next slide just talks a little bit about the effects of misclassifying the request. If a request is misclassified, there would be a delay or possibly a denied access to the drug or service, or there could be delayed access to the coverage and or appeals process. That's why it's extremely important to categorize these requests appropriately once they're originally received. There are procedures for handling misclassified cases. So, for example, if a coverage request was misclassified as a grievance, upon discovery, the plan should immediately forward that request to the appropriate division for processing. They must also notify the enrollee in writing that the request was misclassified and will be handled through the appeals process. If a grievance is classified as a coverage request, the same would apply, that it would be immediately forwarded to the appropriate department for processing, and the enrollee would be notified in writing of the misclassification and that it would be handled through the grievance process. If for some reason the plan issues a denial and the case goes over to the IRE will dismiss the appeal and return the case to the plan for proper processing. I'm sorry. Sorry about that. As a best practice, plans should ensure that the staff, customer service representatives, including staff at delegated entities, are trained to distinguish between coverage requests and grievances and are equipped to process those requests. We also highly recommend that the staff complete the available CMS-based training, which you can find on the CMS website, as well as utilizing CMS account managers as a resource. Okay. In summary, plans are expected to audit their coverage determination, appeals, and grievance systems for the presence of errors and to implement appropriate quality improvement processes as needed. Plans must determine whether the complaint is a request for coverage, a grievance, or both, and complaints must be categorized on a case-by-case basis as determined by facts and circumstances of each request. If plans have specific questions about Part C, organization determination, appeals, or grievances, please forward those questions to the Part C mailbox. And if there are specific questions about Part D, coverage determinations, appeals, and grievances, please forward those questions to the Part D appeals mailbox. At this time, I'm going to turn it over to Paul, who's going to address complaints.
Great. And thank you very much for that, Coretta. My name is Paul Collura, and I am the Senior Advisor for the Consortium for Medicare Health Plans Operations. And I work out in the field alongside your account managers and caseworkers, and it's my pleasure to be with you here today. So let's talk a little bit about complaints and start off with a definition. Plan complaints are essentially an issue where investigation or action is needed on the part of CMS or a plan, often after the individual has first sought a resolution elsewhere. And these situations can relate to a variety of matters, but most commonly involve costs, enrollment, access to care or prescriptions, marketing, or plan customer service. And all of the complaints that we receive are tracked and managed through the resolution in our complaints tracking module, also known as the CTM. The CTM was introduced in 2006, and since then it has come quite a long way. When it was first designed, we envisioned it as being sort of a basic compliance module, but that very first year of Medicare Part D, we were hit pretty hard with complaints, and so we repurposed the system to serve its current function, and it is now the biggest and most widely used module in all of the health plan management system. And the CTM serves two key purposes. First, we use it for a workload management system that allows for the routing of issues, recording of notes, adding pertinent materials, working matters through to resolution. But it's also used to help us at CMS to measure how well plans are doing in adhering to our expectations and making sure that beneficiaries get the high quality, high value health care that they deserve. Plans are expected to resolve matters referred to them in the CTM timely, and all complaints, regardless of who is tasked with resolving the matter, are concurrently assigned to a CMS caseworker. So every parent organization has an account manager and a lead caseworker located in one of CMS's regional offices, and they're tasked with monitoring plan resolutions, and more importantly, they're there to give you the support that you need to help address your CTM complaints. Through a mechanism in the complaints tracking module, we have a feature called plan requests that allow you to request assistance from a CMS caseworker on matters that are outside of your control to address. And internally, on the CMS side, we have an internal standard to respond to those plan requests within 2 business days. Now, earlier this year, we redesigned the CTM, and the changes were made to do a few things. We wanted to remove some of the data elements that were very difficult to collect or really just didn't add value to our data analysis. We also sought to add a few pieces of information into the CTM to, again, support our data analysis, but also help you with complaint resolutions. We also sought to reduce administrative burdens on the part of plans by allowing you to enter certain types of cases directly into the system. And then I think most visibly, we sought to improve the navigation and the scalability and the maneuverability of the system, bringing it more in line with other modules in the health plan's management system. Over 70% of our complaints originate at our 1-800-Medicare call center, and complaints from our call center are transferred through their interface and loaded into the CTM each morning, with the exception of Sundays. About a quarter of complaints are recorded by CMS directly, and these are complaints that most commonly come in through our regional offices via congressional offices, providers, advocates, other stakeholders, and of course, beneficiaries themselves. We have approximately 40 state health insurance programs, or SHIPs, that also use the CTM. We have a small number of complaints that are recorded by our MEDIC, which is our program integrity contractor, after they've determined that a matter that was referred to them as possibly being fraud, waste, and abuse is really better suited for casework. And then the remaining cases come in through our online complaint form or through our MMP state partners. Together, roughly 2/3 of all of the complaints that go into the CTM are resolved by the plans, and 1/3 are resolved by us here at CMS. Complaints are categorized and subcategorized to help assist us with monitoring, and the breakdown by top categories from last year is shown here, and behind all of our categories are subcategories. We have enrollment and disenrollment as our top complaint category, and it's been that way since we first implemented Medicare Part D. And those are situations that can be quite varying, but it could be a person who's having difficulty with their not getting their membership card, they are enrolled in a plan and they think they should be somewhere else, their enrollment request was not processed or processed timely. We also get a fair amount of complaints naturally related to costs, whether it's the co-pays, whether it's the co-insurance, whether it's the premiums. And those can be situations, again, that are quite far-reaching. It could be related to premium withhold. It could be disagreements about the late enrollment penalty that they are facing. Maybe they feel like they're paying too much at the pharmacy or having difficulty getting the best available evidence to be honored at the point of sale. We get a considerable amount of marketing complaints, much fewer than we used to get. And these are complaints that are largely accompanied by a request to change enrollment and are most often associated with an allegation of inappropriate marketing, most typically by an agent or broker. And we share those complaints with our state DOI partners under the terms of a memorandum of understanding. Benefits and access. We see 11% last year. These are usually network issues, people having difficulty finding a pharmacy or getting a prescription filled. And then rounding out the top 5, customer service. This could be difficulty getting in touch with a plan, a disagreement with how a plan customer service representative handled their issue, difficulties getting plan materials, and that can also include materials in alternative formats. And then in terms of other categories, we have provider complaints, we've got program integrity complaints, and good cause as well. Now this right here is probably my all-time favorite CTM-related graphic. It shows right here that the number of complaints filed with CMS has continued to go down. And we know that during this period of time, MA and Part D enrollment just continues to go up. And so this is a real testament to the good working relationship that we have with you to improve the beneficiary experience. Plan accountability, reliable systems, program enhancements, and of course, beneficiaries becoming more familiar with how our programs work have really helped make this the success that you see in front of you. And even though we don't have 2017 on there yet, we've taken a look at the trends. We're expecting another decline. So a good deal of this credit goes to the folks here in the room and those watching virtually. Okay, so now it's time for a polling question. Typically, plan complaints are recorded in the CTM only after a beneficiary or provider has first sought resolution with the plan. Is this true or false? give it another moment or two. Okay, well, the actual answer here is true. And while it may not always be the case, whether it's the call center, CMS, or the SHIP, we ask the complainant if they've first contacted their plan about their issue. And if they haven't, we encourage them to work with you directly first before going the CTM route. We want you to have that relationship with your member, and we realize that you are the best source of information for them regarding their benefits, their costs, and their coverage matters. For complaints assigned to plans, we have timelines for resolution, and they're outlined here. As a point of interest, we have similar standards at CMS for the complaints that we work and that the plans do not get to see. We expect plans to resolve 95% of immediate need cases within 2 calendar days of receipt. On the Medicare Advantage side, we define immediate need complaints as those types of situations where a beneficiary has no access to care and an immediate need for care exists. On the Part D side, we define those as situations where the complainant has 2 or fewer days of medication remaining. Similarly, we expect the plans to resolve 95% of urgent complaints within 7 calendar days of receipt. For MA urgent complaints, those are situations where a beneficiary has no access to care, but they don't have that same pressing, immediate medical need. And on the Part D side, we define an urgent complaint as a situation where a beneficiary has between 3 and 14 days of prescription medications remaining. For all other complaints, we expect plans to resolve 95% of them within 30 calendar days. And if a plan disagrees strongly with the issue level of a complaint, you can always submit a plan request to your CMS caseworker to have the issue level reviewed and changed. So let's talk a little bit about some complaint best practices. When it comes to handling complaints, it starts with effective triage. So for example, if you get a complaint and it requires prompt resolution, even if it isn't classified as immediate need and urgent, we ask that you please give it that immediate attention. And also, in the course of doing triage, check to see if it's a matter that is really within your plan's control to resolve or may even belong with a different sponsor. If it does, get it back to CMS so that we can get that beneficiary the service that they need as quickly as possible. When working complaints, we encourage you to contact the complainant to know a little bit more about the problem. We're limited in how much we actually capture in the CTM about the nature of their issue, and they can always do a better job of explaining their situation than we can ever possibly capture. Acknowledge the issue and let them know that you're on it, because this is really helpful in preventing repeat complaints. The more we can do to reach out to individuals who are very anxious about their issue, to let them know that we've got it. It might take a little bit of time to get it worked, but if you can acknowledge that it's there, usually they're very happy to hear that. When you're working your CTM complaints, always look for additional materials that might be attached, such as billing statements, letters, EOBs, explanatory letters, and so on. Record interim casework notes that document your communications as well as your communication attempts. And many plans are very good at doing this, and thank you for that. It really helps our caseworkers see the work that you're doing even before the matter is completely resolved. And then, of course, notify the complainant of the resolution, letting them know that the next time they have a problem, to try to contact you to directly to kind of work things out. We always try to avoid having matters go into the CTM if we can avoid it. Use the information that Coretta spoke about earlier and use that with your own call center data and RPC reports and any other information that you have alongside CTMs to come up with a complete picture of what your customer's experience is like. Based on what you learn, perform root cause analysis, understand your top issue drivers, and come up with strategies for improvement. Communicate regularly with your CMS account manager as well as your CMS lead caseworker. They're there to help you when you need it. Do not refer beneficiaries to 1-800-MEDICARE, especially if it's a matter that you are expected to either talk about or be able to resolve. We encourage plans to make full use of the SHIP Unique ID program, or in some cases even have a dedicated SHIP hotline, and that helps give our SHIP partners expedited service when they're very often helping a beneficiary when they're face-to-face with them. Complaint volume rises at the end of the open enrollment period, and it continues to peak into January and into February. And so make sure you have adequate staffing during those periods of time to work your complaints, especially if you're expecting increases in enrollment or have made significant changes in your plan benefit design. And then lastly, although it's not listed here, I would also encourage you to encourage your members to sign up for premium withhold if they are receiving SSA or RRB benefits. It helps promote continued enrollment, continued access, and reduces good cause reinstatement requests. We've listed here some of the top resources for you to refer to with regards to complaints. We have a December 2016 HPMS memo that announced the CTM redesign. We have the February 17, 2017 HPMS memo that rolled out our new BAE assistance process, which we believe is a significant process improvement and hope that you're enjoying that change. That's the change that now allows plans to directly enter those cases into the CTM instead of actually sending encrypted emails to one of 10 regional offices around the country. And that process replaced an old one that went back to 2008. The February 24th, 2017 plan SOP is probably the most valuable resource for CTM complaints. It supersedes all previous guidance. It includes a full category and subcategory listing, and it also includes good examples of plan complaint resolution notes. Those same complaint resolution notes, I should also mention, do get funneled back to our 1-800-MEDICARE call center so that if a beneficiary contacts us to know a little bit more about the resolution, what the status is of their case, they're able to provide that information. And then lastly, there is a plan user guide located in the CTM that provides screenshots and explains how to navigate through the module. The great thing about the CTM is that it's very user-friendly and it's fairly intuitive, but that is an additional resource to help you navigate and get the most out of what CTM can do for you. So on behalf of Coretta and myself, we really appreciate your time and attention, and I will turn it back over to our moderator.
All right, thank you. We do have time for questions, so if there's anybody in the in-house audience who has a question, please feel free to step up to the microphone. Okay. And we do have an in-house question. Please let us know your name and where you're from.
Hi, I'm Dorothy Buchholz, and I'm from Johns Hopkins Healthcare Quality Improvement. I'm wondering if there are any best practice tools available for plans to self-audit regarding appeals or initial determinations.
I could barely hear her. If there are any.
I'm sorry, can you repeat that a little louder? Maybe pull the microphone down a little bit so it's closer to you. There you go.
Hi, I'd like to know if there are any best practice tools for plans to use to self-monitor and audit their processes regarding initial determinations and appeals.
There probably is. You may want to, that's a question you may actually want to send to the audit mailbox. That it's something that they may be able to assist you with, or even possibly you're having a discussion with your account manager. It is, I apologize. I will get that information in before we leave out. Okay.
Okay, thank you. We do have a number of questions here that came in from our webcast viewers, so I'm just going to start with the first one. And that is, relating to the topic of appeals, grievances, and complaints identification and processing, does CMS have plans to update chapters 18 and 13 anytime soon to include CMS's appeals, grievances, and complaints identification and processing expectations of the plans? The last release of Chapter 18 was May 12, 2014.
Yes, CMS has plans to release an updated manual by the first quarter of 2018.
Okay, the next question. If an enrollee contacts the health plan to express dissatisfaction, but declines the right to file a grievance, Is it CMS's expectation that these cases are included in the grievance audit protocols?
Yes, if the enrollee does contact the plan and expresses dissatisfaction, even if they don't need additional remedial action, those should be included as a grievance and documented as such. Any additional questions regarding the audit protocols, and I apologize, I actually do have that email address for the young lady that just stood up. It would be part_D_audit@cms.hhs.gov. So any audit-related questions should go to that particular mailbox. And there have been several HPMS memos out regarding the audit protocols, and each one does in fact have that mailbox address.
Okay, the next question. We would like to know more about the intent of the new outreach guidance surrounding the Part B versus Part D drug determination, specifically the weekend coverage. Given that most physicians are not working on the weekends, we are looking for clarification on intent so that we can build an optimal solution.
This was a question where we weren't really clear on exactly what the question was, so it's very difficult to provide the appropriate response. So if the person that submitted that could send that to either the Part C or the Part D appeals mailbox, we will address that.
Okay, the next question. Chapter 18 has not been updated in some time. Did I already ask that one? Okay, we'll skip it. Sorry.
No, actually, you can go ahead and ask
that
question.
I can? Go through that one?
Go ahead. Correct.
Okay. Chapter 18 has not been updated in some time. Are there any new expectations regarding tiering exceptions and how they relate to coverage determinations, or should the plan continue to handle tiering exceptions as listed in guidance?
Okay, so right now the plan should continue to follow the existing Chapter 18 guidelines, as well as there was a policy clarification for the 2018 call letter. So use the existing guidelines and the information that was provided in the call letter. But again, any additional questions, please send to the mailbox.
Okay, next question. If the customer is dissatisfied with the outcome of the DMR request, is it appealable?
Yes, if the enrollee disagrees with that initial coverage determination, which this in fact would be, then yes, they may appeal that decision.
Okay, lots of questions here. Can you please specify how to handle a member who calls in with a complaint, but it is resolved on the call with the customer service representative? For example, a member calls upset because they went for a refill and the pharmacist would not give them their medication. Upon investigation, it is discovered that the member went in 2 days before the refill was allowed. This was explained to the member and they understood and were no longer upset. Should it be handled as an inquiry as the issue was resolved, or should the member be reminded of their right to file a grievance because they had called in upset?
Okay, this still should be processed as a grievance. If the enrollee is ultimately satisfied with the response that is provided on the phone, it does not, and it doesn't require any type of further investigation. The plan should simply document the call, document the issues that were raised and the resolution, and that would be fine.
Okay, this next question has to do with CDAG program audit protocols, and there are 3 separate questions to this. Since the call log review is new this year, we would welcome some clarification on CMS expectations for the following call scenarios. The first one, if a beneficiary calls and expresses dissatisfaction about a plan's service, but the customer service representative is able to resolve the issue during the call, should this be logged or documented as a grievance? If yes, would all the grievance-related regulatory requirements found in Chapter 18 still apply?
So yes, this would still be logged and documented as a grievance, even, again, if you're able to resolve it during that particular phone call. You should, again, document the conversation, what the issues were, what the resolution was, and it would be documented as, as a grievance.
Excuse me. The second question. If a beneficiary calls and expresses dissatisfaction about a plan's service, and the customer service representative offers to file a grievance, but the beneficiary declines and says she doesn't want to do that, should this be logged or documented as a grievance? If yes, would all the grievance-related regulatory requirements found in Chapter 18 still apply?
Okay, so the previous response would be the same for this one. Yes, it absolutely should be logged as a grievance. Can't stress enough that a lot of the grievances will probably be submitted orally, and they may even be able to be resolved during that one particular phone call, but it still should be logged, documented. There really isn't a need to say, do you need to, or would you like to submit a formal request as far as the grievance is concerned, as long as you're addressing the issue and there's no remedial action and there's no further investigation that is required. They would do it orally. If they want the response in writing, of course you would have to respond to it in writing. If, for example, it's a quality of care issue or quality of service issue, yes, you would respond in writing. But other than that, again, just document it, and it would be marked as a resolved grievance issue.
Okay, and the third one, lastly, depending on the responses to the above scenarios, would CMS consider development of a formal versus informal grievance typology with a related job aid for the industry's reference? For example, while both types would be logged, a formal grievance would require plans to satisfy all Chapter 18 regulatory requirements, whereas an informal grievance would be primarily for reporting purposes.
So again, we don't distinguish between formal or informal grievances. They should be logged appropriately. Even if there's no remedial action, you provide them with the response, the resolution, and that should, again, resolve that particular issue. So there are no, at this time, we aren't looking to make any changes as far as documenting it in the chapter guidance as a formal versus informal grievance request. You should just continue to follow what's in the existing guidelines and what is actually in the regulatory requirements.
Okay, next question. In the case that a coverage determination has been denied in the past 60 days, which scenario would be considered a redetermination and should be reviewed as such? A, same drug, strength, diagnosis, prescriber. B, same drug, diagnosis, prescriber. C, same drug, diagnosis. Or D, same drug.
Okay. In all of these cases, they would be handled as a redetermination. If a determination has been made and the decision has been a denial, the enrollee has the right to appeal that denial. So it should be handled as an appeal as long as they appeal it within the required timeframes, and the plan should respond within the required timeframes of a redetermination.
Bless you. What is the responsibility of the health plan when a non-physician, non-member, non-AOR attempts to appeal on behalf of a member? Is it appropriate to decline the request and reference the guidance on who can appeal?
So if it's a non-physician or it's a non-enrollee or it's not an appointed rep, files an appeal and the plan is unable to resolve the issue, determining who is the appealing party and whether or not the they can act as the appealing party. The plan may dismiss the request. It's only the enrollee, the representative, or a physician who is treating the enrolling or maybe acting on behalf of them when filing the appeal without being the enrollee's representative, where you would be able to process those requests.
Okay, next question. If a pharmacy claim is denied due to missing information, such as the NDC number, when that missing information is obtained, can the pharmacy vendor simply reprocess that claim, or does CMS require that this be treated as an appeal?
For the example that's provided, the plan sponsors aren't required to treat this rejected claim as a request for a coverage determination.
Okay. Next question. Related to complaints resolved at first contact, if these should be related to complaints resolved at first contact, if these should be counted towards the compliance grievance figures reported. Example, customer service rep receives a call from a member complaining about a copay. The customer service rep resolves the issue and offers the member a formal grievance. The member indicates they are all set, but situation is marked as a complaint. Should these be tracked and reported to CMS?
Yes, all of the grievances that are received, and even during the initial call, if it's resolved, that should be included in the plan reporting. But if the enrollee, in fact, is complaining about a copay, the plan should determine whether or not the complaint is actually a grievance, a coverage, or an organization determination. But either way, it should be reported in the appropriate category.
Okay, and I have one last question here. The example on slide 5, the enrollee calls the plan and says, my pharmacy said you won't pay for drug X, but I need it. But during the conversation, the enrollee also says they do not wish to start a coverage determination. Confirming it would be correct to not begin a coverage determination at that time.
That would be correct. If the enrollee, for some reason, not sure why, they decided they did not want to pursue the coverage determination request at that time, then you would not have to initiate the process.
Yes. Go ahead, please.
Hi, I'm Jill Ventura from Horizon Blue Cross and Blue Shield of New Jersey. My first question is about the CTM. So I heard you say that when a member calls, you ask the member if they contacted the plan first. We have found that on some research, they have not contacted the plan first. So my question to you is that grounds for a retraction, since that's the criteria?
It's not. We ask the beneficiaries that, and of course we can't do any verification on the front end when they're presenting a very important matter to them. We find out that when we have looked at this in the past and we've asked plans in the past, that the majority of beneficiaries have in fact contacted the plans first. We are not always going to have that be the situation in all circumstances. And I can tell you on the CMS side, when we are presented with something that might be immediate need and that we really need to get your attention, we're not going to hand the beneficiary back off and say, hey, you got to contact your plan, we can't help. So sometimes we will intercede in those situations, but as a general rule, we do try to ask that question and get some kind of confirmation from the beneficiary that they first tried to work with you for the reasons that were described. You know your members best, you know the benefits that you provide and the costs and so on.
Okay, thank you for that. Okay, so a follow-up to that is retractions in general, right? So sometimes a member will come to our plan carrying a late enrollment penalty from their previous plan, and they had no idea it was going to show up on their bill at the new plan, and they call CMS to complain. That's not really an assign. We can't really reassign that anywhere. We can research it and determine that that's correct, that's accurate, it was on their confirmation letter. Again, is there any criteria in which CMS will establish retractions?
Well, I mean, when you're talking about late enrollment penalty issues, I mean, this is something that's universal that all Part D sponsors face. So if we were to do some discounting, we would affect all the plans fairly evenly. So there really wouldn't be a net benefit to everybody. But it's my understanding, and I'm not the enrollment expert here, but the most recent plan that the beneficiary is in can provide some assistance to the beneficiary with regards to getting the LEP corrected and informing beneficiaries of their appeals. So we do look to the plans to provide that kind of level of assistance. And the fact that it has made its way into the CTM is an indicator, because we do ask the beneficiary, have you tried to discuss this with your plan first before going down that route? That it's an indication that they perhaps haven't gotten the necessary response from their current plan. And that's why we enter those cases.
Understood, thank you. And then I have an appeals question. So, similar to what people were asking as it relates to grievances, when a member calls our member service line, our member service folks are able to pay claims. So if a member calls on the phone to say, I don't think my claim was paid correctly, and a member service person looks at the claim and agrees with the member that it was not paid correctly, and they can adjudicate and make that correction on the phone, tell me the story with the appeal rights and all that. What is required at that point? Is that an appeal? Is that a fix on the phone and a documented conversation that it was resolved?
It would be an appeal. It could be, if you accept those type of appeals over the phone, you could clearly document, read back to them exactly what they're calling you about, what the concern is, and then you would go ahead, initiate, and start the process for making the correction for that particular case.
But if you only accept written, for example, if you were only accepting written and you resolved it on the phone, what would be the expected course of action?
Well, I mean, if you're saying they're calling, it was a copay issue, correct?
The claim wasn't paid correctly.
The claim wasn't
Right.
paid. The claim wasn't paid correctly. That is an appeal. If you're saying that you only accept written, then you should probably still follow up with them and let them know that a written requirement, to submit that in writing as well. But I don't think that should preclude you from going ahead
fixing.
and starting the process.
Thank you very
for
much.
making the correction.
Okay, we are out of time for this session, so I would like now to thank Coretta and Paul for covering the key differences relating to Medicare appeals, grievances, and complaints. If you would like to evaluate this session, go ahead and select A and follow the link. Our last session today is the open Q&A session, and this means that all of our speakers from throughout the day are going to join us here on stage, and each session will have a few minutes to answer any questions you have or that were sent in throughout the day. So I will call each session up. They will join me over here to my right, and we will address any outstanding questions. So we will start with the first session, which was Part C and D, Past Performance Analysis with Michael Neuman and Kerry Casey. Come on up, please. And we'll ask our in-house audience again, if you have a question, if you would please move to the microphone in the center of the room. And I will start off with questions that we received from our viewing audience. The first one, can you better define what an extreme outlier is compared to a regular outlier?
So I have to apologize. I think I encouraged this question. There's no difference between an extreme outlier and a regular outlier. An outlier is an outlier is an outlier. The word extreme was merely just as an adjective to connote how infrequent it happens. So regular outlier, extreme, and regular, same thing.
Okay. Next, can you expand the information on slide 13 regarding Part C has floors for the 80th and 90th percentiles of 3 and 5? Does this mean a health plan needs to have at least 3 compliance letters to be categorized in the 80th percentile and 5 compliance letters to be categorized in the 90th percentile?
So what we mean by that is that if the 80th percentile is less than 3, then 3 is substituted and treated as the 80th percentile. And if the 90th percentile is less than 5, then 5 is substituted and treated as the 90th percentile. And I'd like to clarify, so it's not number of letters that this is based on, but it's the score, which is the number of letters multiplied by the weight of that letter. So, for instance, you could get 3 points by either getting 3 notices of noncompliance or 1 warning letter without a business plan.
Okay. And the last question that I have here, for MA plans that were new as of 1/1/17, must they wait until 1/1/2019 to expand their service area since application dates are normally due by mid-February? New plans will be at 13.5 months of past performance. This rule seems to harm new plans in the market even when they've had no major performance issues.
Sure. So we've heard this comment many times over the years, and the idea is that if a plan is new to the program, and I mean brand new, doesn't have a parent that's participating with another legal entity, they have a 14-month requirement before they're able to come in and apply. So in that scenario, 1/1/17, they could apply in 18 for a 19 contract. And the idea is that without those 14 months, just like we're holding everyone else accountable for 14 months, past performance is a risk assessment, essentially, or a risk analysis of how a plan is going to be a partner with CMS for Benny protection, for being able to be in the program. And without knowing that, we can't assume that a plan would be able to handle the rigors of that without having any performance. So if a plan has brand new, we would make them wait 14 months until they can participate. However, we do have a caveat for plans that are under the same parent, different legal entities. They can piggyback on the experience of a parent under a legal entity under the same parent. So that can work. But I think in this case, where it's a brand new entity, you would have to wait the 14 months.
Okay, and that's all the questions that I have for this group. So thank you very much, Kerry and Michael. Next, we have encounter data with Shruti and Monica. If you would like to please come on up. Okay, the first question that we received from our viewing audience. When will CMS provide plans with encounter data report cards in Excel format? And will the agency be making publicly available any of these benchmarking data to which individual plans are compared in these report cards?
Okay, so the Excel format, we're actually planning to do that with the upcoming report card. And we expect to be releasing that this month. And then what was the second part of that question, Stacey? Sorry.
That's okay.
Oh, the benchmarking data. So the benchmarking data in the report cards right now, it's, you know, we have an MA regional, an MA national, fee-for-service regional, fee-for-service national. And so those benchmarks are pretty much the same across, you know, all of the report cards. So the report cards are at a contract level, but the benchmarks you see are what you would see kind of across, you know, the region or the nation. So.
Okay, next question. Can CMS provide any update on its timeline for issuing Phase 3 MAO-004 reports for contracts that were consolidated or terminated as of 1/1/17?
Yeah, thank you. That's a question that we've been receiving pretty often, and unfortunately, I don't have information that I can share at this point in time. But it is something that we're definitely looking into.
Okay. I requested information regarding the rollout of the new MBI Medicare Beneficiary Identification. Specifically, plans need to link the new MBI code to the currently existing HICN to maintain continuity for Medicare Advantage members over time. As a suggestion, perhaps the corrected Medicare ID field on the current RAPS record could contain the new MBI code, while the current HICN is in the Medicare ID field on the RAPS record, providing the link I requested above.
This is very helpful feedback. It's actually something that sounds like it would be very helpful to include on one of our user group calls. So we're going to take it back to the team for consideration in one of our webinars in the future.
Okay. Next question. We received Rejection 02110, beneficiary Hicken, not on file. We checked marks and the Hicken matches what we submitted in EDR. We have contacted CSSC operations for assistance. We have been told that this is a timing issue. However, we continue to receive this rejection. What do we need to do to get the encounter accepted?
Yeah, this sounds like a very situation-specific issue. So we'd recommend that this be submitted to the encounter data mailbox, encounterdata@cms.hhs.gov, and if include as much as specific information as possible. And it would also be helpful to provide ICNs, and we'll take a closer look at it.
Okay, next question. Is there any discussion on increasing the frequency of the monthly user group calls and/or extending the length of the calls to add more time for Q&A?
This is also a question we get pretty often, and it's also something that we're looking into with the user group webinar team, and so we'll take this back also for consideration.
Okay. On slide 24, what is CMS's definition of no-pay claims?
So the definition of a no-pay claim is in the technical notes to our report card too, so you can refer to it there. But a no-pay claim is really, it's a fee-for-service claim submitted by a hospital for the Disproportionate Share Hospital Payment Program, the DSH program. And it's a program that we run to fund the provision of uncompensated care. So hospitals are actually submitting these claims sort of separate from other programs to the office that runs that program.
Okay, the next question we have. Where is the best place to find resources to use while investigating and researching encounter errors?
I think the best place to go where we have a range of information is the csscoperations.com website. And as we mentioned in our presentation, we're trying to consolidate and kind of update that website as well. But there are a number of different resources on that website, and it would be a good place to start to research your errors.
Okay, and the last question I have. Our most recent encounter report card in HPMS is dated June 2017. How are report cards generated, for example, for all plans at the same time or on a rolling basis, other? And when should we expect our next one?
Okay, the report cards are generated all at the same time. So, we take an extract and we report it for all we calculate all the measures for all the different contracts and produce the report cards. And we expect to release the next set this month, sometime this month, so.
Okay, we have a question from an in-house participant. Go ahead, please.
Hi, Jane Faust from Geisinger Health Plan. So I have a couple questions, and I've had the pleasure of talking with Shruti on a couple of occasions, but I know one of the requirements is that we really need to have our providers bill the same as they bill fee-for-service, and I don't think that's very clear in the manuals, so I think that needs to be put out to the industry, because we tell our providers to bill us based on our contracts, and if we really need them to bill us based on fee-for-service information for CMS to do their comparison, it would be a much better way for us to get our provider community involved in how we get them to do that. So even if we pay different, it's still we need those requirements, and I don't think the provider community understands that.
Okay.
So that's a very important point. Okay. My other issue is that the manuals have not been updated in quite some time, so if people that are new to the industry are trying to find out information, they're sent backwards in time, and trying to find the information can be very difficult. So I think that updated manuals would be very helpful to the entire industry. They're great reference materials. I've been involved in encounter data since day one, and I refer to mine on a regular basis. I've got it tabbed, color-coded, everything I can think of, and I don't necessarily want a new manual, but it would be much more helpful.
Right. No, and Jane, those are excellent comments, and we really appreciate that feedback, and we are working on it. As you can imagine, it's a big task because we're trying to go back now over all these years and kind of create something that is understandable to people.
Yeah,
but
yeah,
so
and I appreciate that too, because it's difficult, but trying to keep track of everything gets very hard. And as health plans get turnover too, it's much easier to train incoming staff to go to one resource rather than sending them on a wild goose chase.
Right.
So that brings me to the next point about training. So I attended the training in Florida, which was many, many years ago.
Right.
Randy Brauer, I think, was in charge of that training, if I'm remembering correctly. And so what happened was this was very new to the industry, so people really weren't prepared to ask intelligent questions because they weren't living it.
Yeah.
So now we live it. I mean, we breathe this every single day, trying to get information submitted correctly, you know, follow all the guidelines and make sure that we as an industry or we as a health plan are compliant with complete and accurate data.
Right.
But how do we do that if at the time we couldn't ask intelligent questions? So when you came to visit us, we could ask you one-on-one, but that doesn't help all the rest of the health plans that have to deal with this kind of stuff. So I just think training, again, to the industry would be very, very helpful.
Yeah, and that's really interesting because this morning when we asked how much experience do people have, and
There
was it
wasn't
60% had 1 year or less, and so
Yeah.
that's one of the reasons we asked that question, because I'm trying to understand what kind of information do we need to put
Yeah, and
out
you
there.
wonder if the audience, like here in the auditorium, actually, that's not their big role, but
it's true.
Like even when you asked that question, you had many different points, but we, because we're a smaller health plan, have about 90,000 members.
Right.
We're involved from the day that data gets submitted till it comes back and it gets resolved. So when you ask that question, we could answer yes to every single one of those.
Yeah.
So we have a wide depth and breadth of knowledge, but it's still, it's complicated.
Yes,
that's my answer. So
But those are very helpful comments. Thanks so much.
Okay.
And we are working on it. I mean, especially on the guidance. So we are, and the comment about the fee-for-service as well, like how do you submit, kind of follow some of the fee-for-service guidelines. That's a good one.
It would be helpful for us to be able to communicate that and get our provider community involved so that we could say, yeah, this is what you need to do, because all of those data elements that we don't require to pay a claim, but fee-for-service does, if we could use that as part of our communication with them and our training with them, it would be most helpful. So thanks. Sorry I took so long.
Thanks, Jane. Yes.
All right, thank you. That brings an end to the questions for Shruti and Monica. Okay, next up, leadership chat and roundtable. If you could please join me on the stage. Okay, if you could tell us who you are and where you are from, please.
Good afternoon, Michelle Johansson, Performer X, big fan. So I love these shows, I do. So this question is actually for Jennifer. I really appreciated the plan payment. Oh wait, no, I don't see Jennifer. She's not on the stage. Shall we defer it? Okay. Well, how about this? I'll ask it for the record because I know someone is typing furiously, and then I will accept the fact that somebody may get back in writing or I can send an email. So the question is about DIR, just a general comment. So we love the predictability of Part D versus any other type of government space that we're in. And that the sheet that you had with the calendar is huge. I'm taking that back to everybody. What's not predictable or what's predictably unpredictable is DIR. And I would just like to encourage that you consider including the DIR guidance either as part of the reporting requirements well in advance of us having to do the work or as part of the call letter. Because what tends to happen every year so far is that the DIR draft guidance comes out at the squeak end of May, and the final guidance comes out at the squeak middle of June, and then the documentation is due on the 30th, and it's quite complicated. So if possible, we'd like to see DIR in the predictability space kind of treated like another reporting requirement. Thank you.
We'll take that back.
Thank you.
Hi, I'm Diane Ramey with Navigant Consulting. We get several questions from our clients in regards to how to treat the 2017 ODEG audit protocols and how they apply to supplemental benefits such as dental and vision. Is it the intent that the plans should treat these services and apply the same pre-service organizational determination requirements as they do with the medical?
That I'll have to take back to our subject matter experts, and we can I don't know, Stacey, do we post responses to questions on the website that we can follow up with that?
We are not posting responses on the website, but we will have the transcripts from this that we can.
And we can provide that.
It. Okay, thanks, Vicki.
Hello, my name is Edie Carvalho-Kane. I work for Advent Advisory Group. We have a lot
Could you please get closer to the mic? Thank you.
Hi, I'm Edie Carvalho-Kane from Advent Advisory Group. We have a lot of clients who are DV clients, audit clients, that have been asking us a lot of questions related to the CMS program audit universes and STARS reporting. And they want to sort of forecast where the future is related to that and the connection between the two. If someone can answer that.
When you say connection, are you referring to a specific measure for star ratings or how the validation of reporting requirements comes into play?
It's a combination of all. So for example, I'll take a measure like ODAG. You have program universes that are required for submission, and then you have on the DV side, tech specs. And so plans are trying to figure out how to, whether there's an intent for those to be aligned or remain separate.
At this point right now, and I can let Jennifer, if there's anything else you have to add, they would be separate still. We look at things maybe a little bit differently in the program audits versus other additional data that are collected via the reporting requirements.
Got it. Thank you.
Okay, we'll go to questions we received from the viewing audience. And the first one is, can you provide any update on the timeliness monitoring project, results or future of the project?
I can provide a little bit on that. We did have a very successful collection of that information this year, but we're still evaluating it and thinking about how we can use that information going forward. So we're not applying the TMP findings from the first year of data collection as we continue to analyze it and think about it for the future.
Okay, the second question we received. When will the cutoff happen for the 2017 audits? For example, when will plans be in the clear for 2017?
Okay, so our planned scheduled last engagement letters will be going out at the end of this month, the end of September, but that does not prevent us, if any issues arise, that we can send out a letter or do an audit at any time an issue would come up. But our currently scheduled audits, the last engagement letters will go out the end of this month.
Next question. Can you share when the letter will be sent to MAOs regarding the second plan preview timeframe for STARS?
Today.
Next question. This is a suggestion. The non-renewal service area reduction member notification memo is traditionally released during the second half of September. In 2016, it was released on September 21st. Since sponsors are required to notify members of their options by October 2nd, that doesn't leave much time. It would be helpful if the memo could be released a week or two earlier.
So generally, we release the non-renewal model notice once the landscape has been released, and last year I think the landscape was released later than usual, perhaps by a week, and we recognized that that created problems for plans in notifying their members that they were non-renewing. So one option we're considering is that we would release the model earlier, but tell you to hold those notices until the landscape is released. So at least you'd have them in-house and be able to prepare them, but that's still under discussion. Thank you for that question.
The next question. Regarding applications, it was mentioned that a certain area within CMS is involved with exception requests and look into local patterns of care. Can you please restate which area that is? What specifically does this area rely upon when evaluating local patterns of care?
So I think what the question is really asking is how do we establish our criteria for evaluating where individuals receive services for purposes of establishing the criteria for health service delivery. We largely base that on the patterns of care we see in original Medicare fee-for-service. With respect to exceptions, that is more subjective, and we rely on different sources of information as well as the information that plans provide to us, and then we have folks in the regional office and central office evaluate those exception requests. So they're generally requested for a pattern of care exception. So that's when what you see on the ground isn't really represented in the data we're using to evaluate health service delivery. And all of that information gets fed back into our process as we reconsider new standards for subsequent years. We look at the exceptions that were requested and see if we need to make modifications to our criteria.
Okay, I just want to point out we lost our screen back here. Okay, thank you. Just want to check. And we have one last question. Please advise if there is a release date for the readiness checklist.
It'll be late September, early October at the latest.
Oh, and we have another question.
Sorry, Jane Faust from Geisinger Health Plan again. I get my fingers in a lot of stuff in CMS. So a key to your acronyms, like on your slides, where do we find that? Because it's kind of hard to tell based on what your names and what departments you are in charge of as to what those really mean in the slides. So how do we get that?
Can we modify the slides?
I was going to say they're in the conference guide.
They're in the conference guide.
Okay, well that's easy. Okay. Next question around ANOCs and EOCs, knowing that we're in full swing trying to get those out to the members. Is there any thoughts about changing the delivery date for the EOCs? I understand getting the ANOCs out to the members by September 30th so they can make an informed decision come AEP. But the EOCs, getting them out there, I mean, they're a very extensive document, and as we go through them every year, we find things that we would really like to see changed. For instance, I can think of one in particular is that it says see below or see above. It's not a scroll. Like the member's not going like this, it's a page. Like how do we correct things like that? And how do we work with somebody at CMS, and who do we work with at CMS to see how we can make some changes that we as a health plan see? Because I mean, members don't read them. They're 250 pages. I mean, we all know they don't read them. So how do we as an industry working with CMS make that a better document for the member?
So it's MCAG. That's the Medicare Drug and Health Plan Contract Administration Group.
Okay.
And we're responsible for working through the changes each year to the ANOC and the EOC. We've heard that feedback before, that the ANOC is really the important document that you want to call members' attention to, and the EOC is kind of the big heavy thing that people use as a doorstop. So that's something we're considering. You can certainly reach out to me, and I can put you in touch with members of my team that work on revising those materials each year. And if you have feedback or suggestions or ideas about...
Yeah, we really do. And we think they would make it better, but I mean, maybe it's something we're missing. But so when I heard you in your presentation, October is about the time you start working on the changes
for next year.
For 2019's documents, correct? So if I reach out to you, then you can get me in touch with people.
Sure.
Great. Thank you very much.
You bet. Thank you for the question.
Okay, thank you for the questions for the leadership chat and roundtable. Okay, our next session that I would like to ask to join me on stage, the Medicare Beneficiary Ombudsman and Medicare Plans Working Together. Randy and Michael, and that's it. I do. All right. Well, wait, no, I don't. Okay, so they're both good?
Yeah, that's it, not that one.
Okay, all right, I have that then. I got it. Okay. So it doesn't look like we have anyone in-house with a question, so we'll go straight to the one that we received virtually, and that is, there was a comment made regarding a chat-type function used to work closely with beneficiaries. We have a few questions regarding use of this technology. One, are chats captured so they can be brought forward in an audit? If so, how? Two, what is CMS's stance on capturing beneficiary chats to provide data to CMS on information that is being given to beneficiaries? Are these required in the call log universe?
I'll answer the first half of that and ask Randy to answer the second half of it. So from our standpoint, so we serve beneficiaries in whatever venue works best for them. It's primarily telephone calls, could be social media, could be chat, could be email. If it's in an unsecure environment, like social media, we will shift them into a secure environment, like a secure email or like a telephone call to solve an issue that would be sensitive or contain private information. And then in those venues, we treat all of those the same. So we will record a chat transaction the same way that we record a telephone call transaction interaction via a voice recording system, and then we store that securely and then can recall it for population health work, for quality assurance, or for audit functions. From that point, I'll let Randy take it.
Awesome, and I have no answers for you. Actually, seriously, I would need to go back and talk to my colleagues in CM who were just up on the stage about, the sort of particulars that are being asked in this question. But generally speaking, they're your customers. If you interact with them, you can absolutely maintain that data. You just have to make sure you're paying attention to security, to privacy, all the things that Mike just mentioned. I'm not aware of data from a chat type conversation being something that one reports to CMS or that is used in an audit space, but I don't suppose that that's off the table. Again, happy to take that back to my CM colleagues and get some feedback from them, what that would look like. But I know that, I maintain records of conversations I have with people by text and all kinds of things. So I would encourage that you do that, but always be mindful of HIPAA and other privacy concerns.
Okay, and we have an in-house question.
Hi, I'm Heidi Harmon from Gorman Health Group. And during the break, we had a small discussion, regarding training for communications, basically CSRs who talk with the beneficiary and how they can be more caring and get to the root of the problem. With the advent of the call log portion of the audit protocol, it has come to some folks' attention that a bigger problem may be that the CSRs are just giving incorrect information to the beneficiaries. And I'm wondering if CMS has tracked any outcome from the call log audits, or if you could kind of talk about that problem within the industry.
So it's a great question, and I'll ask Mike for your thoughts as well. But from the plan's perspective, the call log data, I unfortunately don't have a great depth of knowledge about what is done with that information, so I don't want to overreach here. Again, happy to follow up and share information however we share it following these conferences. But what I can say from the universe that I work in is that it happens. People make mistakes. I have not observed any particular trend resulting from a mistake, but I have observed trends in repeated mistakes that helped us sort of focus on, what is it? There's something confusing about our training material, or there's something confusing about our scripts, or there's something confusing generally because, one person makes a mistake, okay, 2 people make a mistake, okay, but if 10 people make the same mistake, something's probably wrong with the material. That's about as deep as we've gotten into that universe, but it's a great question. And I'd love to talk about it sometime. What more can we do in that space? And I think it fits nicely into the idea of sharing with each other ways that we can, learn from that, from those things. Did you have anything?
not with respect to how it's assessed or how it's audited. I would just tell you that you referenced compassion as that term as part of your question, and I mentioned earlier in our panel discussion that compassion is one of the two things that we look for when we're hiring new staff. And for us, compassion manifests itself in ways beyond bedside manner. And I think to the layperson's ear, we say compassion, and people will hear that as saying, well, they're really nice. But for us, we actually create a definition of compassion that we put in the hands of our staff, and then we develop and nurture these aspects of compassion. And one of those certainly is listening and being empathetic, but more importantly, it's diagnosing the real issue that our member is having, whether they can clearly articulate it or not, and resolving that problem, irrespective of whatever procedural guidelines we've put in the hands of that advocate. And for us, that element of compassion has provided the greatest boost of quality for us beyond audits and technologies and capabilities, all of which are important, but the interest of the human being in solving that member's issue is always going to be more powerful than whatever procedures we put in place. So.
All I could say to that is bravo, and I would just say, something that we're focusing on a little bit here at CMS, and certainly I know is important to me, is thinking about the behaviors you want people to demonstrate in a day, and that's one of them. That sort of that level of compassion, however it's defined, really does make the difference, and I think that's awesome. Well, thank you for that. Do we have any other questions? I'm doing your job for you now.
No, that's okay. You can do it.
I think the answer is no, so we will get out of your way.
Okay.
Thank you.
Thank you, Randy and Michael. Okay, our last session of the day. I went too far. Was Coretta and Paul. It was appeals and grievances, and I did ask them all of the questions from our viewing audience already, since I had them up here. Do we have any more questions from our in-house audience? They did have quite a few. I think they get the award for the most questions today. Okay, well, I guess we don't. Well, I'd like to thank them for the time to answer the questions earlier and coming back up. All right, so we go back to that session evaluation. If you would like to evaluate this open Q&A session, please select A and follow that link. And while you are doing that, I just have a couple closing remarks for you. And so please stay with me for a couple more minutes. And first, to obtain your CEU and HCCA-CB CEU credits for today's event, please refer to page 16 in the conference guide. Lots and lots of acronyms today. Second, CMS would like to thank our presenters for their time and dedication getting ready for this day, of course, and all of our in-house and our webcast participants. We appreciate your time that you spent with us here today. If you would like to evaluate today's conference, go ahead and select A in response to I would like to evaluate today's conference. This will take you to a SurveyMonkey link, and you can actually answer the event survey right there. So we do ask that everybody do that, and if not, that link will be emailed to you from CMS at a later time. And I guess that's it. So please take the time to fill out that survey. Thank you so much for attending today. Have a safe trip home, everyone.
Go figure.